Okay. Is my slide still showing, right?
Very well. It's showing
Okay.
very well. Can hear you very well.
Okay, thank you. I've already put it on slideshow,
Yeah,
so
we
it
can
should
see
be
it.
wider now.
Yes.
Okay. All right, thank you very much. We've gone through the permanent pacemaker. Starting with this slide, just to show you a picture of how the temporary pacemaker. We've already seen how the machine look like when we posted one on our. We've also seen. We've tried to understand the different function of the temporary pacemaker, which we described the last time on the group about how we adjust for rate. The one we posted on our group, probably I just reposted just to re-emphasize what we discussed the last time, that for the temporary pacemaker machine, the first knob will adjust for the rate. Depending on the make actually of the machine, you see where you can control it. You see where you can control output. Both the depending on the type. So if it's a dual chamber, then that means you can control output for atrium and for ventricle. But if it's a single chamber, then you can only control on chamber. Now, I actually posted it on the group so that we can remember the knobs. Then I have to start with this slide, as I said, to show us that this is a dual chamber temporary pacemaker machine, and that you can see the A and the V representing the two chambers, atrium and ventricle. And for the atrium, we can see both chambers actually. You can see both pace and sense indicators. So meaning that if your lead is inside any of the chambers, it will be showing, if it is spacing, it will show the indicator, the light indicator, to show pacing if it's in the atrium, and if it's in the ventricle. Then also if it's sensing, it will also be blinking light. So these indicators are for blinking the light. Also, we can adjust to any mode you want. If you notice if we still notice on the group, actually we posted the machine on the group. There are 4 knobs. So the fourth one can help us adjust the mode setting we want. Either the temporary pacemaker also can adjust to a mode setting. If you want a BBI, you want the AA high, DD high, whatever mode you want. But one thing you notice is that it will not give you the 4th alphabet. If you remember, Dr. Duyemi was asking us the last time, why is it that most of the time they only put 3 alphabets? Why not the 4th alphabet? So this is one reason why you will not get the 4th alphabet, because this is a temporary pacemaker machine. The battery is outside. The machine is outside, it's not implanted in the patient. So there's no way you can have a 4th alphabet of talking about rate modulation. We all remember that the 4th alphabet means rate modulation. So to re-emphasize, the 1st alphabet means the chamber pace, 2nd alphabet, the chamber sense, the 3rd alphabet is response to sensing, and the 4th alphabet is the rate modulation, meaning that if the patient is running the pacemaker, the heart rate should be running or increasing in rate as modulated by the pacemaker. Also, why the 5th alphabet we said is the shocking therapy for ICD, either anti-tachycardia pacing or shocking or DC shocking. However, because the temporary pacemaker, the 4th alphabet cannot be there, neither the 5th alphabet. Why? Because the way it is implanted on the patient is an external device. So there's no way you can get a 4th alphabet. If you implanted the pacemaker through a femoral root, the lead is through a femoral root or is through the jugular, there's no way you will be saying that patient can be running and then that you now have a 3rd alphabet to be having rate modulation, so it's not going to work. So that's why I don't have a third alphabet. So that should answer Dr. Duduyemi's question on why most of the time they rarely write 3 codes. Okay, so let's just see how it's meant to function and abnormal function. We've previously looked at some ECGs to determine if what mode of pacemaker we have looked at. We've all discussed that. So we just want to quickly describe some abnormal function of the pacemaker. So this is, we can all agree that this is a pacemaker spike. We are saying, Dr. Tony, I hope I'm still communicating. Hello?
You are
Yes.
still communicating. We can hear you very well.
Yes, please.
Okay, thank you.
Yes,
Thank you.
yes, sir. Yes, sir.
Thank you. So we can see the pacemaker. My arrow is on the pacemaker spike. So we can actually determine which chamber is spaced here. We can see it's before the P wave, so we know it's an atrial pacing spike, and it's consistent. So we also notice that there's no ventricular spike. So although you cannot authoritatively say that this is a single chamber, but you can only see that there's only pacing of the atrium. You cannot see pacing of the ventricle, but you cannot stick out your neck to say that this is a single chamber pacing. But you can still emphasize that there is only one chamber that is being paced currently, which is the atrium, because you are not seeing a pacing spike for the ventricle, and it's consistent. So probably the reason maybe we are not seeing the pacing spike for the ventricle could be that probably it still has a good AV node and the ventricle is having normal intrinsic activity. So the pacemaker will not pace because there is normal ventricular intrinsic activity. But that does not rule out the fact that there might still be a lead in that chamber. Okay, so move to the next slide. So one thing I want us to notice is that the difference in the shape of the QRS and the pacing spike. So here we can see that we can also see one pacing spike in front of the QRS, and the QRS is wide, is broad. So trying to tell you that there's a ventricular pacing here, and when there's a ventricular pacing, you are not likely to have a normal QRS. So it's just like a patient that is having VT. It's not likely that his QRS is going to be normal and narrow complex. It's likely to have a wide complex QRS simply because the area that is generating the pacing is in the ventricle. So the same thing stands for ventricular pacing. If you are pacing the ventricle, it's unlikely that the QRS will be narrow, except you are pacing the ease bundle. When you are pacing the ease bundle, remember that the electrical current will pass through the normal conducting fibers, which is the right and left bundle, and to the Purkinje. So in that time, the QRS might be normal shaped and narrow. But if your pacing lead is in the walls of the ventricle, either the apex, RV, wall, anywhere outside the bundle, then you are going to have a wide complex QRS. Sorry, I hope that is clear, Dr. Dudian.
Yes.
Very clear.
Okay, great, thank you. So for this, we know that we are seeing 2 pacing spikes. So there's one pacing spike on my arrow, and there's another pacing spike close to the QRS. And you can still notice that the QRS duration is broad, telling you that you are pacing the ventricle, not around the bundle of it. And there's another pacing spike facing the atrium. So meaning that you have a double chamber pacemaker here. Okay, so this is dual chamber pacing. All right, so we'll go to this other one. This is just similar to one of the previous slides we saw, that you are pacing the ventricle, but you cannot see an atrial pacing. But there's something important here is that this ventricle is closely related to the atrial activity. So you are not seeing a pacing spike on the atrium, so you are not sure if there's a atrial pacing. But one thing you are sure about is that there's ventricular pacing, and that the ventricular pacing is very closely related to the atrial activity, meaning that there's constant PR in interval. So this can be defined as two things. One, it could be that this patient has double chamber pacemaker, and that the atrial lead is not pacing, but the ventricular lead is communicating with the atrial lead, so that you have a ventricle that is trailing the atrium at a constant rate. So it means that the atrial lead is sensing, but it's not pacing because there's no problem with the atrial activity. But the same atrial lead is communicating with the ventricular lead. So ventricular lead, when it paces, is tracking the atrial activity. I hope that is clear.
Yes, sir.
Focal is clear, right? Good.
Yes.
Another thing could be that there could be only one lead in the ventricle, but that same lead has a portion in the atrium that is sensing the atrium. Remember, there was one slide we showed, which I'll go back to that slide. Let me go back to that slide. That showed that could be one lead in the ventricle and another segment in the atrium that is sensing. So this slide, I don't know if you can see this slide.
Yes, sir.
Yeah, so you can see this slide that there is a single pacing lead, which is in the ventricle, but the one in the atrium is not pacing but sensing. So it's still a single lead, but the ventricular lead is the only one pacing, and the atrial lead is sensing. So you're using the ventricular lead to track the atrium. So it can be functioning, and you'll be thinking it's a double chamber pacemaker like this. Unlike this double chamber pacemaker, there's pacing lead in both atrium and ventricle, so they can still communicate. The same thing for this slide. There's only one lead in the pacing lead in the ventricle, but the atrium can be sensed because it's a special lead, so they will still communicate. So it can be making you look as if you have a DDD mode, although it's only the ventricle that is pacing. So that will help us explain that slide, that ECG slide that we were discussing. Okay, so go back to our discussion.
I'm on call tomorrow, but I heard that tomorrow is sanitation. I may go after sanitation.
Okay. Okay, so as I said, it could be that on this slide, it could be that there is atrial lead that is just sensing, not pacing, because we can't see a pacing spike, and a ventricular lead that is pacing and tracking the atrium. It could also be that there's only one single lead, which is ventricular lead, and the segment of that atrial, that same lead has a segment in the atrium that is sensing, so you can use it to track the atrium. So other problems of pacemaker, so we can have problems with the pacemaker settings or pacemaker lead itself. So what are the problems we can have? One, it may fail to capture. So if it fails to capture, it will not pace. If it fails to sense, it will be overpacing. Okay, and you can have different forms of even funny heart blocks from the different abnormality of either the capturing or sensing. So you can have both working back phenomenon generated by pacemaker. You can also even have complete AV dissociation, which will give you a pacemaker syndrome. So pacemaker syndrome simply means that when there is dissociation of the atrial and ventricular activity leading to features of heart failure, like a complete heart block, then that's a pacemaker syndrome. Okay, so let's look at some ECG slides that can explain all this. So we'll notice something here on this slide. So I want us to notice something on this slide is that, please, if I'm moving too fast, let me know, because we need to transmit this knowledge to solve that Brownword part, so I won't have any delay during resolving Brownword questions. Okay, Dr. Okoki?
I think we're
Yes,
with you.
sir. Yes, sir. Thank you, sir. I'm with you, sir.
Dr. Caroline, are we on the same page? Dr. Dudu Yemi? I'm not hearing anybody's response. Their response.
Dr.
What's happening?
Dudu.
Right here, sir. I'm here.
We can
Okay.
hear
Dr.
you very
Ugo.
well.
Dr.
Dr.
Ugo.
Ugo, you are be quiet.
Hey, I'm here, Chief. Good evening.
Yeah,
Chief.
it's good to hear
Okay,
your voice.
so please, we just need to be sure. All right. So I can move on now, right?
Yeah.
Yes, but Dr. Ajayi is not here yet. I don't know why.
Dr. Ajayi,
I've sent him a message. I've called him.
Did he pick? Okay, thank you.
okay, we can move on, right?
Yes, Chief.
Yes, sir.
Okay, great. So these ECGs are important when we are solving the Brownwell question, so there will not be delay. So I want us to notice something on this ECG. So if you notice this ECG, that we can see, bringing my arrow out, so we can see a ventricular activity at the beginning of the ECG. We can see a QRS activity. That's a ventricular activity. But you notice that you're not seeing any more activity for a long time, like there's a pause. Then later you now start seeing another activity, then another activity. So first is that let's recognize the pacemaker spike. My arrow is over the pacemaker spike now. Now, after that ventricular activity from the pacemaker, we're not noticing any other thing. Then later, after many seconds, we now see another pacemaker slide, a pacemaker spike. Then another pacemaker spike. Now, so my question is, what do you think has happened between the first QRS activity and the next one? Dr. Ugo. Dr. Ugo. Dr. Ugo.
I'm here, Chief. Do you
Yeah,
call
so
me?
so what do you think has happened?
There's a spike. There's a QRS. Then there's a T. Then that's failed to pace.
So we can notice that after the pacemaker spike that generated ventricular activity, the first one,
Yeah.
there was a long pause, right? So there's a reason for that long pause. One thing you notice that between that spike, between the first QRS complex and the next one that came, in between, during the period of the long pause, you are not seeing any pacemaker spike. If you notice,
Yes.
you didn't see any pacemaker spike in between. So it's trying to tell you something that he did not even attempt. He did not attempt to pace. There was no attempt to pace. Because if there was an attempt to pace, you should have even seen the pacemaker spike, right?
No response.
And no response, exactly. So since you never saw a pacemaker spike, that means there was no attempt to pace. And so I want you to not deceive us something. Why do you think it will make an attempt to pace? Dr. Ugo.
Maybe he's not able to pace.
No, there will be something else.
The battery.
Remember, the third alphabet. What does the third alphabet say? Dr. Ugo.
I'm trying to remember now.
Remember the coding. The first alphabet means what?
The chamber paste,
Second alphabet.
the chamber sensed.
And the third alphabet should be what?
Okay, response to pacing.
Response to sensing.
Sensing, sorry.
Response to sensing, meaning that if he senses, he should not pace, he should inhibit, right?
Yes.
Abi, you understand? So that means that since you didn't see any pacemaker spike, that means it was inhibiting all along. It was inhibiting pacing.
If you explain this thing well, this thing just said.
Don't worry, I will explain it to you. I just want you to get that the meaning of that alphabet. So we explain to us the meaning of the third alphabet, and we'll apply it to this place. Dr. Ugo.
Yes, Chief.
Yeah, the third alphabet, what does it really mean? What's the interpretation of the third alphabet?
Sensing. Okay, if if I'm now
Yes,
confused.
correct. That is if it sense.
If it senses,
Yes.
It will inhibit. That if it senses, it means
Exactly.
that it will inhibit and
Exactly.
now intrinsic activity. To now have its own activity.
Exactly. Fantastic. 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 So that's what I want you to get about that third alphabet. If it senses intrinsic activity, then it should not pace. It will inhibit. Right?
Yes, too.
Okay, good. So I want you to now look at this slide very well. You see all this baseline reading, these artifacts. Can you see that this artifact?
Yes, Chief.
It is sensing it as a native activity. The pacemaker was actually sensing this thing, thinking this is normal, the patient's normal electrical activity. That is why it was inhibiting all through. So this artifact was sensed by the pacemaker as an intrinsic activity. So all this while, it was thinking that it was intrinsic activity. So that is why it was inhibiting pacing all through. Did you get that, man?
Yes, Chief. Thank you.
Yeah, so Dr. Ugo, I want you to remember there was one time one of our colleagues asked that why should we do a VOO? You know, VOO means that pace the ventricle, right? Don't sense, right? And don't respond to sensing. Remember first alphabet, chamber paced, chamber sensed, and response to sensing, right? So if you have a VOO, it means that pace the ventricle, right? Which is the chamber paced. O means don't sense. The second alphabet, chamber sense, don't sense, right?
Yes.
And don't respond to sensing, the third alphabet, meaning that just be pacing the ventricle only. Remember, we explained that the reason why you use that mode is because when a patient is going to the theater, there can be use of diathermy machine in the theater. Remember?
Yes,
and the diathermy machine will be acting like depolarization, electrical activity, and the pacemaker lead will be sensing the diathermy machine, thinking that it is the heart that is generating intrinsic activity. And so it will be inhibiting pacing. Are you getting me, man?
Yes, Chief.
So in that situation, the patient can go flatline on the machine. Why? Because the pacemaker is thinking that electrical activity is going on, not knowing that it is sensing diathermy electrical machine. Are you getting it, man? So in that kind of a patient going for surgery, we are supposed to convert them to VOO so that the pacemaker machine will not sense any activity. It should just be pacing the ventricle, because it can be missensing diathermy as if it's a normal intrinsic activity. So it means that this kind of patient should be converted to VOO because it is sensing abnormal reading, thinking that it is normal electric activity. Are you getting me, man?
Yes, Chief.
So all we are trying to emphasize here is that it is over sensing activity in this place. So that is why it is not pacing. Okay?
Yes, Chief.
All right. This question is in Brownwood, though, so I want you to remember. We will call you when it's time. When we're looking at Brownwood. You get? And that's why if you look at under it, you see the Brownwood Heart Disease Textbook, 7th edition. So I need you to just understand this slide, Dr. Ugo.
Yes, Chief.
Okay, so we'll move on. So you can see, as I explained, it's over sensing, and there's a problem with the sensing. Dr. Kopi.
Yes, sir. I'm here, sir.
So can you see the second slide?
Oh,
Dr.
wow. Nice
Duduyemi
one.
was Dr. Duduyemi.
Yes, sir.
Yeah, did you get the previous slide, the explanation for the previous slide?
Yes, I do.
Okay, great. Thank you.
Yes, sir. Thank you.
So, Dr. Kopi, so what do you
Yes,
think is
sir.
happening here?
The pacemaker is pacing, but it's not generating any activity. Elliot. The
Fantastic.
pacemaker
Thank
is
you.
pacing.
So
Yes.
what is pacing? The pacemaker is pacing, but it's not generating, it's not capturing.
It's not capturing, so failure.
So what we are trying to say is that you can,
Can I see this?
yeah, so you can see this pacing spike. You cannot see activity after that pacing spike, right?
Okay, but I can see the
So
ventricular
there's a failure to,
activity. That means it's a dual chamber pacemaker,
yeah, so you have a dual chamber pacemaker, sure.
and there's ventricular activity.
Yeah, exactly. Okay, so I think we've talked about oversensing before. I don't think I should bore us with this because this is actually the EGM on the machine. This is EGM on the programmer. So anytime, anywhere you are seeing VS, you are actually saying that it's ventricular sense. Anywhere you are seeing VP, it means ventricular pace. So you can see that you're having a lot of ventricular sense at close interval and a ventricular pace here. Now, but if you look at the ECG above, you notice that it's not regular. Even though it's telling you VS, ventricular sense here, but there's no electrical activity, there's no ventricular activity on the ECG at these intervals. So let me take one for example. I'll start from the beginning. So you see a VP, my arrow, I hope you can follow my arrow.
Yes, sir.
It's
Yes,
the
sir.
EGM, the VP, and if you look at the VP means ventricular pace. If you look at the ECG, it looks like a paced ventricle because the QRS is broad, right?
Yes, sir.
So you see the next VP also, you will see the QRS is broad. It shows that the ventricle is being paced, right?
Yes.
Now you see a VS, it means that ventricular sensed. And you notice that it actually sensed it because the QRS look like an intrinsic activity, right?
Yes.
Okay. Now, if you go to the next one, it's saying VS, under ventricular sense. But you cannot see ventricular activity on the ECG. Right?
Yes, sir. Yes.
Then if you go to the fifth one, it's not telling ventricular sense, but you cannot see ECG activity. And again, another ventricular sense is close to it, although you can see ECG activity.
Yes.
Which is intrinsic. So you are not seeing another ventricular sense close to that again, but you are not seeing corresponding QRS activity. So it's telling you that this pacemaker lead is oversensing because it's sensing, but we cannot see the ECG activity of what it is truly sensing,
Oh,
right?
yes.
But it
So
does not have
sorry,
any
sir.
problem with patient. Yes,
But
I'm listening.
why is it not that is the one not okay? That is the person that is not pacing. That thing is sensing, but what do I want to say now? That is the one that is not okay.
You've not said anything.
Yes, I know. Why? Okay, I think I'm missing it with pacing. That maybe
So
is the
why is it
okay.
not pacing that's faulty, right?
Yes.
Because every time it says VP, it's ventricular pace, and you can see actually the broad QRS corresponding with it above.
Okay.
If you see the next
Okay.
last VP also, you can see
Yeah.
the broad QRS corresponding with it.
Yeah. Yeah.
But every time it's telling you VS, not everyone has corresponding
So the
QRS
only
activity.
correct sense is those two that he was able to see,
Exactly. So
third
it's over.
and the fifth one. Okay. Or the sixth now.
Yeah.
Okay. Okay. Thank you, sir.
So that's just over sensing. Okay.
Sensing.
I don't want to disturb. There are many things that can cause oversensing. Either the machine is being too sensitive, meaning that you have reduced the sensing threshold a lot. It's sensing unnecessary activity. It can be sensing. In fact, if you reduce the sensing and sensing a lot, it can even be sensing muscular activity and thinking that it is electrical activity,
Wow.
even ordinary muscle movement. You know, some muscles have our skeletal muscle have myopotentials
Yeah.
at small degree.
Yeah.
So it can be
So
sensing that and be thinking that it is cardiac activity.
sir, I have a question.
Yes.
Why is it wrong to oversense? What will it do? Does it pass any
Eh,
electric current? What?
okay, fantastic.
Ad block and A
Yeah,
system.
why is it not good to? Why
Oversense.
shouldn't it oversense? It should just oversense and oversense for itself at least. So
Yeah.
why is
So
it
look at this.
worrisome?
So look at this slide. You can see the problem of oversensing. Remember, we are here when we're discussing this slide. So we said that
Yes,
this ventricle is paced here, but you can see there was a
yes,
long pause, right?
yes, yes, sir.
Simply because between the first QRS and the next QRS, this artifact were oversensed and he was thinking that this is ventricular activity.
Intrinsic. Ah,
Can you see it? So
okay.
simply, so you can see that the patient can go into AC study because every time you sense, that means that it will inhibit pacing. And it
Mm-hmm.
means that when there's no electrical activity, when there's no true depolarization, and it's inhibiting patient, patient will still be collapsing and tell you that doctor, that thing where I tell you where they collapse before you put this battery, it still they
It's
happen.
still
Oh.
there.
You
Okay.
not be wondering. I not be telling you, I've seen patients that will come and meet you and I tell you, doctor, I'm not teaching you your work, oh, but I don't think that this thing where you put is
It's
working.
working. Okay.
You guess. uh
Okay. Okay.
So you now understand why you cannot be working with oversense.
Yeah.
Okay. So before we round up, before we go to the EP class, I think I should just show us one or two slides again. So Dr. Duduyemi, can you help us trash this?
Okay. Uh, okay. Okay, the first there was a pacing, ventricular pacing that was followed by it, by a contraction, by then there was another there's a P wave coming after, then another pacing, but that wasn't followed by any visible contraction. Then we can see another P wave, then another uh pacing. Well, I'm not too sure. Maybe it's that pacing that gave rise to this contraction.
Fantastic. Fantastic.
But looking at the size, unless it's a PVC, it seems
Fantastic.
to look like the initial one, the first one we saw with the pacing and
I get you.
the yes. Then I'm not too sure why we have the pacing on the other side in the next one to that. Then I don't know. Then it seems as if there was another pacing that went halfway. Uh, sorry. Okay, I'm not too sure, but there seems to be another pacing spike just after the one that went up, that goes up. Then I'm not sure it is this our pacing that is giving these contractions, Sha. I don't
Fantastic. Fantastic. So your final diagnosis will be failure to
pace, right?
is failure to capture.
Oh
This is
yeah,
not
failure
capturing
to capture.
ventricular activity. Okay, so you are completely right. So just to re-emphasize what you said, you the first pacing spike, you will have thought it gave rise to this QRS, right?
Yes, yes,
So the second pacing spike, you cannot see any QRS with it. The third
yes.
pacing spike, can be 100% sure that it didn't give rise to this QRS. Why? Because they are so far apart.
Okay.
And this is actually a ventricular escape region. Okay, so you now see
Yeah.
another pacing spike was not capturing anything, and you know that there's no pacing spike related to this QRS. So this is another ventricular escape region, and another pacing spike, no QRS, and like that. So it's not capturing. So
So,
thank you
sorry,
because yes,
I have a question. Why is that this other spike going the other way around?
yeah.
We can see
So
that.
if one interesting part is that when it tries to capture the first time and it doesn't capture, it increases the voltage. Probably will tell you that maybe because the voltage you used the first time. That's why you said minimum voltage, the threshold. Threshold means that the minimum voltage necessary to capture depolarization. That is the definition of threshold. Are you getting it?
Yeah.
Minimum is in excess.
Yeah, the minimum
Okay.
energy, the
Okay.
minimum voltage you need to capture depolarization. Are you getting it?
Yes, Chief.
That's the meaning of
Not
threshold.
really, not really. This threshold we are talking about, I was thinking that it is this threshold that gives rise to the depolarization, or maybe
And that's what meaning now. The energy, the
okay.
definition is the energy you need
Yes, sir.
cause depolarization. That's the meaning of threshold. The minimum energy. Okay.
Okay.
How many? So the question you ask us, how many volts do you need to cause depolarization? So
Okay.
depending on
Okay.
the ability of the myocardium, the energy necessary to cause
Okay.
depolarization in the myocardium.
Yes.
Okay.
Okay.
So
Yeah.
that minimum energy or minimum voltage
Mm-hmm.
is called threshold.
Okay.
That's just the simplest definition for it. And when you have a threshold, you also have a safety margin. When you program it on your programmer, you also have a safety margin. A safety margin simply means that if the threshold does not capture it, the battery can automatically increase energy
Yes.
itself. You don't have to always come there to come and be increasing the energy yourself. So it is an automated form that If I use, let's say we use 0.5 millivolts to generate QRS, that's
Yeah.
the threshold of the patient, the minimum voltage. It does not mean that 100% of the time it's only the 0.5 that will generate QRS. The myocardium can change in nature, and you'll be needing higher energy to generate the same thing, to generate the QRS. So maybe it can change to 0.7. Later, the tissue can change to 0.8. So the question is, will you be always coming every time to come and be changing the programming? That okay, oh, after 1 month, oh, I noticed that your energy has increased to 0.8. Yeah, come, let me increase the threshold. Come, let me increase the threshold every time. No, it will not happen that way. Or else
Yeah.
before a patient comes to you, you can just be, they will just be in a flat line. So that's why the battery, the battery itself can now reprogram itself that it can double the energy just to create a capture. Are you getting me, man?
Yes, sir. Yes, sir.
So that's why they call it safety margin. Safety margin means that the voltage, the threshold times 2 of the voltage is created as by the battery as a safety margin. So that if the minimum voltage does not capture, it can gradually
Can
be
go
increasing the
higher.
voltage itself until the day you meet the patient and reprogram the patient again. So when you are getting to that safety margin, you can have larger spikes like this in opposite direction. Okay.
Yes, sir.
All right. So there are many reasons for failure to capture. It could be that the lead are dislodged, meaning that you are just seeing patient spike. And the moment the lead dislodges, the battery will not be emitting a lot of energy, thinking that probably the energy it was issuing was not sufficient to cause depolarization. So to be increased, as we explained before, it will be increasing the energy, increasing the energy, increasing the energy. And the problem will be that it will be consuming the battery. Because the higher the quantity of energy you use, the faster you consume the battery. Okay. So it could also be that the lead that you kept there fractured. If it fractures, it will still not capture, and it will also be wasting energy. Okay. I hope it's clear, man.
Yeah, very clear.
Yes, sir.
Okay. So those are different. I'm just trying to show different reasons why you can fail to capture, and it could be the problem with the electrode. It could be electrolyte abnormality, but the end point would be that it will drain the battery. It will drain the battery. That's why we said it increases spacer's output. It will be increasing the output, but draining the battery. It will be increasing the energy used, but it will be draining the battery. Okay. All right. Okay. So, Doctor, hmm, Doctor, Doctor Bernard, Doctor Bernard, shall we toss, sir? Do us the honor of reviewing this. Okay. Doctor Bernard is number. Doctor Kopi.
Yes, sir.
Yes, sir. So, can you see this slide, sir?
Yes, sir, I can
What will
see.
you explain about this slide?
Okay.
So, I want you to start with how many chamber,
First, it is a dual chamber
dual
pacing.
chamber, fantastic one. What else are you noticing?
And there is uh, well, one thing I noticed is that it is pacing the ventricle very well, but then you could see P wave,
Fantastic.
but it's still pacing, whether there's P wave or not. So it doesn't really sense the atrial activity. just paces on his own. It's like it.
Fantastic.
Yes.
Fantastic. So just to buttress what Dr. Kopi has told us, so if we look at this, first we know it's dual chamber because we can see one person spike here. You can see another person spike here. Okay. One person spike here, another person spike here, one person spike here, and like that. But one important thing here is that we can see a P wave, right?
Mm.
Yes.
But
Yes.
at the same time, you can see the atrial pacing spike not related to this P wave. Because you expect that if you have seen a P wave, then there should not be pacing of the atrium again, right?
Yes, Chief.
So that means you did not sense that P wave. Okay?
Yes.
And the same thing, if you look at this place, you could think, oh, probably there is coincidence because the pacing spike is just landing on the P wave around there, sub 2 P wave here. But if you look at the next one, you know that there's no relationship between this pacing spike and the P wave. And like that, like that. So that means that this atrial lead has a problem. It's not sensing the P wave. It's not sensing atrial activity. Dr. Ugo, I hope it's clear. Man.
Yes, Chief.
Yeah, great. So we can move on. Okay. So Dr. Okopi, once again,
Yes.
can you look at this one?
Okay. This one looks also a dual chamber pacing.
Dual chamber.
Um, dual chamber pacing, but you could see that yes, there are some it just paces anyhow, especially the ventricle. Of course, I can't see P wave, so it's okay. It's pacing the atrium without seeing any atrial activity. But there are some ventricular activity with narrow complex PRS where it paces
Fantastic.
matter. So
Fantastic.
it doesn't sense ventricular activity, so it paces despite the ventricular activity going on.
Fantastic. Thank you, Chief. So we can see clearly here that there are two pacing spike, one atrial activity, another one here, another one here. It's clearer here, one atrial activity, and you can see this ventricular activity pacing spike. We can see ventricular activity pacing spike, ventricular activity pacing spike. We can see ventricular activity pacing spike. So what we are trying to emphasize here is that one is that the atrial pacing is good because you can see a small P wave here where my arrow is. Okay. You can see another P wave where my arrow is. But where we're going is that the ventricular lead, look at this ventricular pacing spike, is coming after the QRS. So it means that this ventricular pacing spike did not recognize this QRS. So there's problem with sensing, at least at this place. Then if you are look at this is a normal QRS activity. Intrinsic. Why? Because it's narrow complex. It looks like an intrinsic activity. But you are still seeing a pacing spike even when the QRS have started. So you are seeing a pacing spike in the middle of the QRS. So it means that that pacing spike is not recognizing this intrinsic activity.
Yes.
Okay, Dr. Judy, I hope it's clear.
Yes, sir. Thank you.
So there's a problem with this ventricular lead. It's not pacing, it's not sensing ventricular activity. Dr. Ugo, hope is clear.
Yes, Chief.
Dr. Blessed, I've not heard your voice. So. Okay. I want to be sure we're on the same page, sir.
Fully with you, sir.
Okay, God bless you, sir. Okay, so we'll be rounding up soon. Sorry, just okay. So, Dr. Blessed, what do you think is happening here?
Just a second, just a minute to look at it.
Is the slide clear? Dr. Blessed?
Yeah. Yes, very clear, sir.
Yeah,
So
very
what do
clear.
you think is happening?
Chief, is the hard one you now brought for me.
Dr. Blessed, leave that side now.
You're a hard man, Dr. Blessed.
The first, I noticed that the first pacemaker spike, there is also a ventricular activity from that pacemaker spike. Then there's a P wave, intrinsic P wave with an intrinsic the narrow complex QRS complex, but the pacemaker still went ahead to
Yes.
and then the next one also at the same rate as the first, the one preceding it, P wave, and then QRS complex intrinsic, and the pacemaker is also discharging, and then intrinsic P wave, narrow complex QRS, narrow QRS complex. And then just shortly after that, pacemaker is discharging.
Fantastic.
And then so actually the heart is doing just fine. And the pacemaker is like there's a VVO going on concurrently, and then there's intrinsic cardiac activity at some point that is also going on concurrently. Because if I look at the pacemaker discharging 1, 2, 3, 4, 5, the rate is steady. While it's regular. It's a regular discharge from like VOO, sorry. Like there's a VOO going on, then the intrinsic activity of the heart is going on at some point. But we notice that why there is no ventricular activity from the pacemaker discharges in some of the QRS complexes because the heart is refractory. When it meets that refractory period, after the refractory period, the pacemaker actually generates ventricular activity.
Yeah, right, sir. So thank you very much, sir. We appreciate your response. It's accurate and explicit. So just to emphasize that number 4, number 5 simply spells it out that is not sensing ventricular activity. It's just so. Dr. Bless, I will ask you one question. What do you think will happen at number 5 if it's consistently happening that way? What do you think can lead to this number 5 spike? RNT. So that explains the next slide. Okay. Can you see this slide?
Yes. I'm going to.
So that's what can happen.
Like
when it's not sensing.
Yeah.
Okay. So Dr. Do you hear me?
Yes, sir.
So you can see one of the questions he asked was, why don't we just leave it if it's over sensing or it's not sensing? You can see what it can lead to. So if it is not sensing and you just pace on a non-sensing activity and you pace on the T wave, then the next thing we have is VF. Wow. So you cannot joke with non-sensing or over-sensing. So if over-sensing, it can go to a flat line. If it's not sensing, then you can go to here. Okay. So
Okay. Yes,
I think so. Then a pacemaker can also give you a Wackenbacking phenomenon. So Wackenback, I'll just quickly explain this. A Wackenbacking phenomenon simply means that there's a problem with the programming. It's also a programming problem where
Okay.
it gets to a stage where the pacemaker, what you have programmed, there's a PFAB. PFAB is just like just like the PR interval. You can also program it on the pacemaker. So especially when the patient has a single pacemaker lead, if he has just one ventricular lead, and that ventricular lead is now trying to trail the atrium, you will notice that there was some time where there was one slide. Let me try to find the slide that shows how far away the P wave is from the, I think it's there. The P wave is far away from the paced ventricle. That although you are pacing the ventricle, but the P wave is far away. So there'll be time where you'll be having progressive prolongation of the P wave and a drop in QRS. Sorry, I want to go and look for the slide up there. Sorry, just 1 minute. Yeah, so this slide. So you can see that there's no relationship between this P wave and this QRS. You can see how progressively prolonged it can be. Meaning that there can be time, it could be narrow, and sometimes it can get progressively prolonged, and there'll be a drop, which is what we see in Wackenbach phenomenon. So the same thing can happen in a pacemaker when there is no communication between the atrial lead and the ventricle, or it's not sensing the atrium. It's getting it, sir, and it's just pacing the ventricle only for a single lead. So you can have a Wackenbach phenomenon. Are we getting it, sir?
Yes, sir.
So you can have that. So that explains the Wackenbach phenomenon that can happen in pacemaker. Then again, a pacemaker cannot give you something like look like an heart block, especially when it's not capturing or it's not sensing. So there'll be a disconnect between the atrial and ventricular activity, and you give you something like a complete heart block. Okay, so there is heavy desynchrony. From all the programming abnormality we have explained, there can be non-sensing or non-pacing, over-sensing. So you can, any of it can generate into something that looks like a complete heart block. Okay, and the patient will now become symptomatic. Okay, so that's what you call a pacemaker syndrome. Hope it's clear, Dr. Did you hear me? Dr. Kopi?
Yes, sir. Yes, sir.
Yeah, so there can be a stage where there can be abnormal programming that it will generate and lead to what we call AV desynchrony and lead to features of heart block, complete heart block. Okay, we've talked about the importance of diathermy and pacemaker, and there's some MCQ questions we have solved it before in chapter 1 of Harrison. Or I'm not sure if we have solved it, but I think it's in Harrison. And we've discussed everything about diathermy and pacemaker. Okay, the patient can go into asystole. Okay.
Yes, sir.
So it's recommended that if you're going to use a diathermy, use the bipolar diathermy. Don't use monopolar. It has less electrical activity generated when you use bipolar. Oh. Number 2 thing you can do is to put the patient on VOO, which we have previously explained. Okay. Another thing you can do would be to put a magnet. So that's the importance of the magnet. So you can put a magnet on the pacemaker battery or an ICD, and it will go into a VOO mode immediately. Are you getting it? So if your programmer is not with you to convert it to VOO, moment you put a battery on that pacemaker, it will go into a VOO mode. It will not sense, it will not respond to sensing, it will just be pacing. Okay? But for an ICD, it can inactivate the ICD that it will not discharge. Okay, so a magnet can, so you can use a magnet in a patient that is having multiple shocks. Maybe he has an ICD in him and is discharging indiscriminately. You can quiet the ICD by putting a battery on it. Are you getting it, sir?
Yes, sir, we are getting it.
The magnet, I mean, so if you put a magnet on the ICD battery, it will make the battery go into an inactive mode. Okay? And it can also convert a pacemaker to a VOO if your programmer is not there. All right. Okay, so thank you. Any question before we go to the invasive EP?
Yeah, Chief.
Yeah.
Hello, but I don't know
Yeah,
whether we
still
still have. I don't know
Is
whether
that
we
what?
still have. I want to ask about something. First, it would be great if you don't mind if you can have access to this slide.
Yeah, I'll send it to the group now.
Okay, that would be great. Thank you so much. Then the other thing I wanted to also ask about is issues of pacemaker interrogation. For typical
Yes.
PV stop, something like that.
I didn't get it clearly.
Pacemaker interrogation.
I
know that is a full discussion again, but you know, I still remember the pattern of PV stop for pacemaker interrogation. So maybe if you can throw some light on it, would be great. Then thirdly, some of us, we see this patient in our clinic for patients that had done pacemaker outside or out of our centers that have such facilities. So they've done the pacemaker. And most times they come to you in the clinic and you don't have the programmer to be able to interrogate the pacemaker properly. I remember when I was interested for that period, we interrogated ICD and the pacemaker. You have to use the programmer's machine to be able to do that properly. But if you have to do that with the limited equipment we have, what do you think what's your advice? Where we don't have, of course, we don't have a pacemaker equipment, we don't have the machine to interrogate the pacemaker, and now the patient comes to us in the clinic and asking us that I did a pacemaker some time ago. I want my cardiologist to assess me to know that this pacemaker is still fine. So what's the minimum we can do while the patient is withdrawn before probably sending the patient to the interventional cardiology, wherever he did it? So what's the minimum we can do?
Yes, sir. Okay, so I can respond to your question, sir.
Yeah.
Right?
Yes, sir.
Okay, Chief. So the minimum you can do, I'll start from the last question. The minimum you can do is to do an ECG and look at the tracing. We have described different types of ECGs and what can happen to the ECG. So from your ECG, you first know, before a patient comes for programming, he said that he should do an ECG before you start the programming. Identify the problems on the ECG. Listen to the symptoms of the patient before you start touching the programming setting. At the end of your programming setting, it's important to repeat another ECG to be sure that whatever you have programmed has been affected, or while you are programming, there was some abnormalities or some mistakes made while doing the programming. The patients that are fine, the ECG were normal, and we just told them to just for programming so that we can know the battery life. And by the time the person that did the programming touched the whole thing like this, it just, in fact, you can't even explain what the person did. And by the time patient came back, it's now going to view or some funny readings. You now be wondering, okay, the patient had a normal activity before going for your programming. After the patient now returned, reading can't change. We've seen things like that. So the first basic thing is the ECG. Does that ECG have any problem? Does the patient have symptoms related to pacemaker syndrome? Or is it still having symptoms of abnormal function of the pacemaker? Somebody that had pacemaker because of the current syncope. After pacemaker, syncope no stop. Or after some time, syncope returned. And he gets passing out, he's still passing out, or he's still having bradycardia that made him to have even go for the pacemaker itself. Those symptoms are important. It's telling you that there's a problem with the programming or with this pacemaker activity. Okay? So do an ECG. Review your ECG thoroughly before you send for programming. And the reason why you're using your ECG thoroughly is that after the programming, you expect perfection on the ECG. So that means you still have to repeat an ECG at the end of the programming. You understand, sir?
Yes.
Number two is that we all know programmers are not bots. You can't buy programmer. No matter how hard your hospital try, you can't buy it. It's only given by those companies, and there's a reason why they release it. They release it based on volume. So all those tri-states you have gone to another, they never bought. It's because of the volume of procedure they've done. That's what made them entitled to the programmer. So that's why we're advising our cardiology. So if your hospital does not have programmer, is they are trying to tell you that, okay, you need to start implanting. So Chief Tony, there's no way you leave tri-state and not start implanting your center. They have called you to competition and fight. So take over from your seat cardiothoracic surgeons. Don't you know your cardiothoracic guys, their residents are they are implanting? You should know.
Yeah.
So why are cardiologists now folding their hands and sleeping? Okay, all right. So, but you can't buy the programmer. The programmer can only be given to high volume centers. I've sat with those guys. They only give it to high volume centers. Okay. Yeah. So you asked something about pacemaker interrogation. Professor, that thing is not hard. It's simple and straightforward. But I think there are some keywords we need to check in the pacemaker when we are doing pacemaker interrogation. It's just simply related to at least a portion of what we have been discussing. One is this: when you are interrogating a pacemaker, you want to check the baseline function you kept there. Is it the same thing that is still active? Remember, we have done this. You have looked at the symptom of this patient, and you want to first, from your ECG, is there a problem with capturing? Is there a problem with sensing? Or is there a heavy desynchrony generating a pacemaker syndrome? First, analyze all that. So when you have analyzed that on your ECG, that is what you are going to focus on when you are doing the programming. So, bro, I want you to forget about all those technicians doing programming. You have a clinical knowledge of what you are doing and why you are doing it. So I don't want you to get caught up with interrogation. It's not just about the interrogation, it's about analyzing. Is a patient you are treating. So you want to, a patient has paid a lot of money to get this battery, to get this pacemaker. Is it delivering what you intended it to achieve? If not, what are the problems? And how do I sort that problem? The only way to sort that problem is doing the interrogation and now reprogramming the pacemaker. So if you have looked at your ECG and the patient has failure to capture, then when you're doing interrogation, you now check what is the threshold. Is the threshold you programmed when you implanted, is it the same threshold now? If I increase the threshold when doing my interrogation, will it improve capturing? If yes, then that means that the tissue is now resistant to the previous threshold. That means you need to increase your threshold. Are you getting me, sir?
Yes.
That is when you talk about increasing threshold, increasing pulse width. Increasing pulse width simply means that, let's say I was using a threshold of 0.5 millivolts with a pulse width of 0.5 milliseconds. It means that for 0.5 seconds, this guy is going to release 0.5 millivolts to generate a QRS complex or generate a P wave, whichever chamber you are looking at. But if my threshold is not generating that QRS or depolarization, then let me increase my threshold to 0.8. Will it generate the QRS I'm looking for at the same pulse width of 0.5? Meaning that the duration, if I generate 0.8 millivolts for at 0.5 milliseconds, will I achieve acceptable depolarization? Or do I need to go to as high as 1 millivolt or 1.5 millivolts? Just remember that by the time you are getting to 1.5 millivolts to generate a threshold, then that means that there's a problem with the lead, or the tissue is become really resistant. So it's either the lead has fractured, the lead has dislodged, and the next thing I need to know is where's the location of the lead. That means I have to send the patient for chest X-ray. So let me post something to our group. In a patient that had failure to capture. Just 1 minute. I'll post something on our group now. Dr. Tony, I hope you're still with me.
Yeah, very much.
So I'm sending this thing to the group now. And I want us to play, it's trying to load. So just give us a example. This patient I'm sending to the group had a pacemaker implanted, a single lead pacemaker lead, because the elderly and she had syncope, recurrent syncope. Are you getting me, sir?
Yes.
So we had to implant that lead. Before her discharge, we're getting a heart rate of 60 beats per minute. Before, she was having a heart rate of 25 to 30. But after the implantation, we did the ECG, heart rate was 60 beats per minute. She was doing fine. So, have you seen the video?
Yes.
It's supposed to be on the group now. It was a ventricular lead. Are you getting it? But yeah, a month after, she started having the syncope. And the children now started saying that the pulse rate has reduced to around 30 again. No, what is happening? Are you getting it? So, can you play the video? Can you notice something? Can you see the lead on the video? On the chest X-ray?
Yes, I can see it.
Are you getting it? So, what do you notice on that lead?
It's that doesn't look.
Did you see the lead?
I can see the lead.
Yeah. So you can see that the lead. Okay, I will show you one more picture so that you can make up your mind. Just 1 minute, I'm coming. So I want you to compare.
Sorry, sir. What about the lead in the video? I don't.
Can you see the lead?
Yes.
You notice the lead is where? In which chamber?
Like
the level.
Look at that lead very well.
The right chamber. The right.
Yeah. So that lead has dislodged into the right atrium.
Yeah, the right.
Are you getting it? That lead has dislodged into the right atrium.
The right atrium. So what? Okay. Where was it?
Hello? It was previously in the ventricle. Are you getting me, sir?
Yes, sir.
The lead was previously in the ventricle when we implanted it. Our ECG was normal, as in we're generating a good. But when she came, we just noticed that I'll send the ECG to you after the procedure, after the first procedure. I want you to look at that ECG. Have you seen the ECG? After the procedure, Dr. Okopi, can you see the ECG?
Yes, I can.
You can see that that's the rhythm strip, right? You can see it's coming at a constant rate.
Yes, yes.
You can see that the pacemaker spike is related to the QRS.
Yes, yes.
Right? That was after the procedure. But by the time that lead dislodged a month after, she was back into complete heart block.
Oh.
So that's what gave it out to say that somebody that was fine with a rate of 60 beats before discharge, how come it has gone back to 30 beats per minute? Are you getting it, sir?
Yes, I get.
So it means that there was a dislodgement of that lead. So anything could have explained either the lead has fractured or the threshold, it was not failure to capture if it has gone back to complete heart block, or there was a dislodgement of the lead. Are you getting it, sir?
Yes, sir.
So I'm just trying to emphasize that when we did the programming, we noticed that the threshold was very high, meaning that it was sending a lot of energy to capture, but still not capturing. So we just asked the patient to do an ECG, so an X-ray, chest X-ray, and just showed that the lead has dislodged. So we have to go back to the theater and reposition the lead. Are you getting it?
Yes, sir.
So that is before the patient became now fine. Now patient is fine now and is doing fine. So I'm making you understand, Dr. Tony, that pacemaker interrogation is not just they are just going to do interrogation. You have to first look at the symptom and the problem, analyze your ECG before you now go and start interrogating. Okay? Another aspect of pacemaker interrogation is sensing. As we have all seen the different ECGs, it can be over sensing. Yeah, tell me.
Please, what's interrogation now?
Interrogation means that you just want to go and check the setting of the pacemaker.
But it's working well. You just want to check it.
No, you want in this one you are checking the settings. Is when you know if it's working well or not. Just like what we just explained for interrogation means that let me analyze this pacemaker that I have implanted. Is it doing what it's meant to do or is malfunctioning? If it is malfunctioning, what is the cause of the malfunction? Is it that the lead has dislodged? Is it that the programming has problem? Programming has problem means that is he over sensing? Is he under sensing? Are you getting me, ma?
Yes, Chief.
Is he having failure to capture because the threshold is not sufficient to capture? Or is it that the battery life has expired? So you can see that there's a lot of things to be done under interrogation. Are you getting me, ma?
Mm-hmm.
Okay? Is it clear, ma? Is it clear, Dr. Ogo?
Yes, Chief.
Okay, so that's what we do in interrogation. So, Dr. Tony, I hope you are following, sir.
Very well.
So that's the same thing you check. You check for the sensing. You check for is it over sensing? That means you have to reduce the sensing amplitude. Are you getting it? So if it's over sensing, that means you have to increase the sensing amplitude. It's opposite. If it's under sensing, that means you reduce the sensing amplitude. Okay? I just don't want to bore us a lot with this pacemaker programming. What Dr. Tonita will not delay many things. I think the best thing first is, let me see one of the days I can bring the programming home, the programming machine home. Then I will now make a video of what we do. It will be easy to follow better that way.
Yes, sir. Thank you so much.
Yeah, it will be easier that way and better that way. So that people will not get confused.
Yes, sir.
Okay. So can we go to the EP lectures? So we know
Yes,
yes, sir.
Okay.
Okay, so I'm going to share the slide for the EP. Dr. Blessed, hope you are with us, sir. Dr. Dudu Yemi, hope you are with us.
I'm here, sir. Yes,
Okay.
sir. Thank you, sir.
So this lecture is very important. I want people to be alert for this one. Please, this
Okay, sir.
EP class is very, EP1 is very, very important. And I'm sure I'm taking it as the last EP. Sorry, I'm trying to look for this slide. Sorry, I'm trying to. Just 1 minute. I'm trying to share the slide. Okay, is my slide showing now? Hello?
Yeah. It's up now.
Okay. Thank you. So, we've previously gone through some parts of this EP. So we've previously gone through some part of these EP lectures. So what we are doing today is we all know the mechanism of arrhythmia. We won't waste too much
Yes,
of
sir.
time with this one. Yeah, the first thing I want us to pick is this phenomenon in the mechanism of arrhythmia. I'm talking about SVTs, now complex tachycardia. I want us to note what they call RP interval and PR interval. We all know the meaning of PR interval, and RP interval simply means that between the QRS complex and the subsequent or following P wave. So I want us to note the word long RP interval and short RP interval. Conditions that will give us long RP interval are the normal conditions of sinus tachycardia, atrial tachycardia, whatever. It will not affect the RP relationship. One important word again is that some AVRT will also give us a long RP interval. Now, short RP interval is what I want us to really focus on. Conditions that will give us a short RP interval. So we can see it in this slide. A short RP interval can be seen in conditions of AVNRT, AV nodal reentrant tachycardia. We'll still explain why it does that. I thought we've previously talked about this before, but we'll still explain in this course of lectures why you can have short RP interval. We also know that some form of AVRT can also give us short RP interval. That's the most important thing, the short RP interval. AVNRT and AVRT simply meaning that there is a accessory pathway, and that is why the RP interval is short. There's an accessory pathway. Okay. I have to also bring up this slide to still just buttress the fact about the conducting fibers. This looks like a normal conducting fiber. Now the next slide shows us how the catheters are positioned when they are doing EP studies. Remember I said catheters are passed from the femoral through the femoral vein, either on the right or on the left femoral vein. It passes through the IVC and lands in the right atrium. Sometimes catheter can be passed from the jugular too, but 99% of the time is from the femoral vein. And as I said, you can pass as a lot of catheters you need as much as possible. The femoral vein will accommodate them. You can pass up to 5-6 catheters. So we can all see the distribution of the catheters. So we can see this catheter, the catheter in the right atrium, upper right, I right atrium, HRA, I right atrium. Okay, close. Just you want to get it as close to the SA node as possible.
Yes.
Yeah. Hello.
Yes, sir.
Okay, so you can pass a catheter close to the east bundle. So you see this catheter over the AV node and east bundle, depending on the level you want. You can also pass another catheter through the coronary sinus. This one is not showing well, but it's trying to pass through the coronary sinus. Okay, you can pass another catheter into the right ventricle. Remember that the image is not showing here, but you can pass another catheter. You can pass a catheter puncturing the interatrial septum to gain access into the left atrium, or you can pass a catheter also through into the left ventricle through the interatrial septum, then across the mitral valve into the left ventricle. Okay, sorry. All right, so I also have to put up this slide to show us the importance of the variants, where some people have two tracks, a fast and a slow pathway. And these are things that generate the AV nodal reentrant tachycardia or the accessory pathways. So for this now, both the fast and the slow pathway is inside this AV node. Okay? Yeah. So that when we're explaining AV-NRT, you understand that the accessory pathway we are discussing is inside within the AV node. Then it also explains why there's a short RP interval. Okay? Meaning that the R wave is occurring before the P wave, or the P wave is embedded inside the R wave. I have to bring up these pictures just to emphasize what it can mean. So this is a slide trying to explain how the conduction system can go in a retrograde direction into the atrium and in an anterograde direction into the ventricle, following these conducting fibers, especially in patients that have AV-NRT. Okay? Hope it's clear, Dr.
Very clear.
Ugo. Okay. So if that portion, if those preambles are clear, so let's quickly use this material, this diagram, to explain the concept of AV nodal reentrant tachycardia. Okay? So we can see in patient, we've already previously said that patients that have AV nodal rentals and cardia, they have two pathways. They have the slow conducting pathway and the fast conducting pathway. So the alpha here is the slow conducting pathway. The beta is the fast conducting pathway. Are you getting it? So in a normal day, when they are in their sinus reading, the only pathway that will be functioning will be the fast pathway because it's faster than the slow pathway. So it's the first person that conducts from the atrium into the ventricle that would continue to conduct activity. Okay? So it is the fast pathway that will conduct because it's faster than the slow pathway.
Yes.
So that means most of the time, the slow pathway will be blocked when they are in their sinus reading. This is blocked because the fast pathway has overshadowed it. So there's nothing for it to conduct. Okay? Dr. Ugo, is it clear? If it's not clear, let's know, man.
Dr. Ugo, is it clear?
I just want to be sure we are on the same track because it's very important before we start going to the EP diagrams.
Ugo, is it clear or Ugo is
Dr.
sleeping?
Dudu,
Ugo is still here, but maybe I don't know that she's sleeping now.
I think she's sleeping.
Dr.
Yeah,
Dudu,
So I was around when you explained the first image A, but I'm not so sure I heard any other thing. I remember you saying that the beta one is the fast pathway, the A is the slow one, and in a normal condition is the beta that move
because it's faster.
the electrical activity. Yes.
Yeah. So what we are trying to say is that when they are in their sinus reading, okay,
Yes,
when the patient is in sinus reading, the fast pathway is the only guy that is active. The slow pathway usually blocked. Why? Because the fast pathway has overshadowed the activity.
Yes, sir.
Okay, great. Now, when problem arises is in this B.
Okay.
Normally, so I'll still first go to the A again. When it conducts from SA node through the AV node, remember we said there are two tracks in the AV node, right? Alpha and beta, fast and slow.
Yes.
The fast will take it to the ventricle, okay?
Yes, sir.
Then you wait for another SA node discharge.
Coming.
At a regular interval. By that time, the AV node is already has left its refractory period, right? Ready for another conduction. Okay? And the fast takes over again and conducts to the ventricle, right?
Yes, sir.
Yes, sir.
However, problem arises when the patient goes into atrial premature complex. So when there's an atrial premature complex, know that it's not coming from SA node, right?
Yes.
Yes, sir.
It's coming from any other place outside the SA node. So at that time, atrial premature complex occurs. I want you to follow my arrow. Remember the fast pathway has already conducted the previous SA node discharge. Right? And it is now in its refractory period. So meaning that it cannot conduct. Right?
Yeah.
But because the premature complex will want to conduct itself, it will pass through the what? Slow pathway. The slow pathway, which is waiting for opportunity, will now take over. Right?
Yeah.
You get it now? So moment it takes over, then by the time it is getting to the ventricle, remember the ventricle is in its refractory period at that time because pathway has to just depolarize it. But the fast tract has now left refractory period.
Yes.
then that means the fast pathway can now take over from the slow pathway and conduct upward, because the tissue can conduct both downward and upward.
Upward.
But it did not conduct downward because the ventricle is still what? In the refractory period at that time. But
From
the fast
slow wave,
pathway
right?
is now, yes, through the, you know, remember it's passing through the slow wave now.
Yes, yes.
So the slow wave will now take it. Are you getting me?
Uh-huh.
And the fast pathway now has left refractory period. So that means that the fast pathway can now take it upward back.
But why can't he take it and still continue to the ventricle?
Because the ventricle is in the refractory period at that time. Any
You
tissue
can't
that is in the
affect
refractory
anything
period
from
will
it.
not depolarize. Are you getting it?
Yes.
So the fast pathway will not take it over backward, upward.
Great, yeah.
Are you getting me, man?
Yes, sir. Yes, sir.
And by the time it's coming upward, the slow pathway too will now take over. That brings you to C. So slow pathway takes over. Are you getting me, man?
Mm-hmm.
And slow pathway can take you to the ventricle now, because the ventricle will have left the refractory period. But remember, the vicious cycle has started. The fast pathway is taking it back to the atrium. The slow pathway will take. Yeah, so the slow pathway will now take over from the fast pathway, which is taking you to the atrium because it's that left refractory period, and take you to the ventricle. And by the time it's getting to the ventricle, the fast pathway has left the refractory period, is taking over back to the atrium. Okay, so that's where the tachycardia circuit occur. Are you getting me, man?
Yes, sir. Yes, sir.
So the question is, how does it manifest on an ECG? Remember, there will be tachycardia, number one. Number two is that it will be narrow complex. Why is it narrow complex? Because you are still conducting to the ventricle using the normal conducting fibers. Are you getting me, man?
Can you please go over it again?
Yeah. So what I'm trying to emphasize is that all these fast pathways, slow pathways are coming in the AV node, right?
Yes, sir.
And that means that whatever they will be taking to the ventricle will still pass through the bundle of His.
Yes.
Pass through the right and left bundle branch.
Yes.
Pass through the same Purkinje fiber.
Yes.
And to generate the QRS ventricular depolarization.
Yes, sir.
And because it is passing through the bundle of the natural conducting fiber,
yes.
That means that the ventricular depolarization will generate will be narrow complex.
Yes.
Right?
Yes, yes, sir.
So that's why AVNRT will give you a narrow complex tachycardia.
Okay.
Even though you are passing through fast and slow pathway, everything is still within the AV node tissue.
Okay.
Do you get it, man?
Yes, I do.
And the AV node is only connected to the east bundle. And the east bundle is only connected to the right and left bundle. And the right and left bundle is only connected to the Purkinje. Okay? So no matter the speed that is occurring in the AV node, it will only be generating narrow complex.
Okay.
You get that one now. So that's why it's narrow complex.
Yes, I do. But I have a question.
Yes, ma'am.
Thank you so much, sir. Now, you know, it's the A pathway is the slow pathway coming down. Now, and in this AVNRT, it is actually the slow pathway that is coming down, and it's the fast pathway, which is meant to be the original pathway that is meant to carry, that is now taking it back to the atrium.
Correct.
Now, in that wide complex, so I thought is the accessory pathway.
No, we've not gotten to the wide complex.
Okay.
I want us to just focus on the.
Okay.
We'll get to the wide complex. I will explain. But remember that AVNRT is always narrow complex.
Okay, sir.
Right?
Yes, sir.
except if the patient has bundle branch block. If the patient does not have bundle branch block, it should be narrow complex. It should always be narrow complex. Okay?
Yes, sir.
Yeah, we'll get to
Right.
AVRT, but I just don't want us to mix it up. I just want to get the concept of AVNRT.
Sorry, sir. Aside from it having a pre-existing bundle branch block, what of if it's also having a preservatory syndrome associated to?
And that is not an AVNRT, that is AVRT.
Oh, okay.
AVNRT means atrioventricular nodal. Nodal. AV node. AV node reentrant tachycardia.
Okay.
Nodal. And that's why I kept emphasizing that all these fast and slow pathways within the AV node tissue.
Yes, sir.
And that's why that's why I brought this slide. That's why I brought this slide, just to emphasize
our
the
AV
AV node
node.
tissue. That whatever fast and slow pathway we are talking about inside this tissue.
Occurring within.
Yes.
Okay, sir. Okay, sir.
And this AV node is only and always connected to the east bundle. And the east can only give rise to the right and to the left. Are you getting me? And it's the same right and left that will generate Purkinje fibers. So no matter the fastness of whatever is happening in this AV node, are you getting me, man?
Yes, sir. Yes, sir.
Only thing that you'll be generating will be conduction, depolarization through these normal tissues. And as long as you are depolarizing the ventricle through this normal tissue, it will be narrow complex. It will always be narrow complex.
Okay, sir.
So that's why I've not brought out accessory pathway.
Okay.
I'm not talking about AVRT. All I'm talking about is AVNRT.
NRT.
So you can see the reason why I had to put up this picture, just to emphasize it. So it's not as if I don't know that we all know AV node and bundle of this, but I need to bring this thing out to emphasize buttress while we are hammering on this.
Okay.
Do you get it, man?
Yes, sir, I do.
So AVNRT will always be a narrow complex. Okay?
Yes, sir.
Except the person has a bundle branch block. Do you get it, man?
Yes, sir, I do.
Okay. Dr. Kopi.
I got it clearly. Very clear.
Chief Blessed.
Fire down, sir. We're together.
Okay. God bless you.
We're together. Fire on.
God bless you, sir. So now,
Dr. Ajaya is still here. He has not said
Dr.
anything.
Ajaya.
He is meditating. Let's fire on.
All
Why
right.
am I missing? Now, Dr. Ajaya. Okay. Thank you. Thank you for showing your voice. No, he's not sleeping. No. He has shown his voice. He has shown his voice. Dr. Godia, President, sir. I salute you.
He's coordinating a meeting.
Sir.
He's
coordinating a meeting. Okay.
Yes, sir.
He's with us now, Dr. Kofi. Thank you, Dr. Godia.
I am gallant here. I'm following.
Yeah, thank you. He's our
okay, God bless you.
By
sir.
September, he will be NANT president. He's not far away again.
But I have seen our juice. He's already using our juice to show Kaftan.
Dr. Kofi, I'm not in that thing you're talking about.
This discussion is recorded.
Okay.
All right, sir.
Okay. All right. So we can move on now.
Yes, sir.
Any question before we move?
No, sir. Let's fire on.
Now, because that will bring us to the issue of short RP. Yeah, that's why we discussed the concept of the short RP. The short RP. So you understand the reason why I brought out short RP?
Yes, sir.
This image.
Yes,
short RP. There's a reason why I brought out this short RP. I want you to first notice on this ECG the closeness of the R to the P wave.
Yes,
you notice that? In fact, in some situations, the P wave can be embedded into this R, into this QRS complex. Okay?
Yes, sir.
And the reason is not far-fetched. So you understand why I had to bring out this slide first. Now, let's go back to this. So let's go back to this circuit. So you can see in this circuit that what is conducting to the ventricle now is the slow pathway, right? As Dr.
Yes, sir.
Duduyemi rightly explained. And what is conducting back upward is the fast pathway. You can see the B. The B clearly shows us the B. You can see the figure B. Figure B, you can see slow pathway is going down, and the fast pathway is taking it back to the atrium. Are you seeing it?
Yes, sir, we can see it.
Yes.
So what it is simply telling us that by the time slow pathway is generating QRS complex, because that's the guy going to the ventricle, the fast pathway has quickly taken it back to generate a P wave.
Hmm.
Are you getting me?
Yes, sir.
Yes.
So what we are trying to emphasize is that by the time you are having a QRS complex, it is almost this at simultaneous time you are having a P wave.
Hmm. Yes.
So it simply means that the R wave and P wave will be colliding.
Mm-hmm. Mm-hmm.
That is this information is very important when we are looking at the EP study. The R wave and the P wave, we are generating QRS, the fast pathway has quickly taken it back to the atrium. QRS and the P wave will be colliding with each other. So you have a short RP interval. You have a short RP interval. Do we get it?
Yes, sir.
We got. Yes, sir.
Yes, I do, sir.
So,
Yes.
so you can see one explanation for. So in AVNRT, the RP interval is short. It's short because whatever is happening within the AV node, and the fast pathway is conducting fast into the atrium, making the P wave almost colliding with the QRS. Okay?
Mm-hmm. Yes, sir.
So that should detoxify
I understand what
AVNRT
you
for
said.
us. Yes.
Sorry, okay. Because
Yeah.
that the other picture, the other slide, the second option there, the differential, we are not there yet, Sabi. The one, the blue one. Not this. Not this. Yes, this one.
This one.
Yes, sir. You've asked us to hold on, no? But you know, it's also seen in orthodromic. We should not go
Don't
there
worry,
yet,
I will explain
right?
the orthodontic.
Okay, sir.
I just want you to get. I've not gotten there. I just want you to understand the AVNRT first.
Okay, okay, I'm getting it. Thank you
I
so
want
much.
you to first be sure that AVNRT, if it's clearly understood, why
Yes,
it causes short RP. I just need you to understand that. Right? It's clear, right?
Yes, sir. Very good. Thank you.
So we can move
Thank you
on.
so much. There, sir.
Thank you.
Yes,
All right. So we'll come to AVNRT now. AVRT now. AVRT. I need to emphasize something on this AVRT. Dr. Tony.
Yes, I can hear you.
Chief Tony, do you still have that slide that we used to explain AVRT one time like that?
Yeah, that.
Okay, I think I've seen it. I want to post it back to the group.
Okay, it's on the platform.
Okay, you've seen it. You've seen it on the platform. I think I've posted it
Okay,
back
we
to
have
the
this.
group. But
Is it a
what I
PBL?
should do is the
Okay, I've seen it.
no,
I've
not
seen
the
it.
PBL.
Yeah, I've seen it.
Okay. Yeah, I want to bring up that picture on my slide
Good.
there. Give me 1 minute to just put it up on my slide so I can use it to explain. So give me just a minute to pull it up on my slide. Please, just bear with us. Just bear with me. So that to make our the extent, I want to just add it to my slide. It won't take long. I thought I had kept it on my slide. Let me very much. Okay, so I'm trying to share my screen back. Yeah, I have to bring up this slide so that um, I can nail the point very well. So it might look blur, but I think it will achieve the aim. Okay, I have to screenshot it. Yeah. Sorry, 1 second. Okay, I want to be sure. Can you see my screen, sir?
It's coming up. Yeah.
Is it up?
It's up now. Just
Yeah.
put it
Yeah,
slideshow.
it is. It is up.
Okay.
But maybe
Yeah,
on
so let me put it
slideshow
on
it's
slide.
clearer.
Alpha.
Yeah,
Okay.
it's fair enough.
Okay. All right. So I'm going to use this to explain AVRT. So first, I will start with this slide. So Dr. Duduyemi wanted to find out AVRT. This one is AVRT. AV, atrioventricular reentrant tachycardia. There's no N in it.
Okay.
So that's what differentiates AVNRT from AVRT. AVRT simply means atrioventricular reentrant tachycardia. Okay?
Yes, sir.
It does not say, it's not talking about AV nodal. AV node is not participating
Yeah.
in the problem. Are you getting me?
Yes,
Yeah.
sir.
So I want you to now look. So that is where we talk about.
Hello, sir. Hello.
Guys, I have some little lentil problem. It will come up.
Okay.
Dr. Ugo, are you back? Dr. Ugo. Dr. Ugo. Sleeping.
He's sleeping.
Wow.
He's left. Dr. Oladimeji has left. Let's hope he comes back soon.
Quiet, but they're picking everything.
Okay. So I can go ahead now.
Yes.
Yes, sir.
Okay, thank you. So I'm trying to use this slide to explain AV reentrant. The node has is not partaking of this thing. The AV node is just doing its own function normally. It's not the culprit here. Okay?
Okay.
So the culprit here is that there is a extra tissue that is called the accessory pathway that is outside the AV node. Unlike the previous one, AVNRT, the two tracks was in the AV node. But here, the AV node has only one track. Are you getting me? but the guy that is perpetrating the act is outside the AV node. Okay, it can be any, and is connecting the atrium and the ventricle together. Okay.
Yes, sir.
There are some for the Wolf Parkinson White one. That one has a bundle of what? Kent as the accessory pathway. For the Long-Gannon syndrome, that one has bundle of what? James, right?
Yes, yes, yes.
As the name of the accessory pathway.
Yes,
we have other small ones. For the Long-Gannon one, is that there is a connection between the atrium and the AV node.
Wow. Wow.
That's how, and that's why in MCQ, Long-Gannon syndrome, we give you a narrow complex tachycardia.
Tachycardia.
Okay?
Yes.
Are you following me?
Yes, sir. Yes,
there
sir.
are the Mayhem fibers, the Mayhem type. Mayhem type, that one is just, you can have nodofascicular, you can have atriofascicular. That means they're just connecting the atrium to the fascicle.
The fascicle.
It's connecting the atrioventricular, small fibers. Sorry, I didn't bring all their pictures, but that is just the different types you have. They are all classified under the group of AVRT.
Okay.
Okay. So there are many.
Yes,
so it's
sir.
not only Wolf Parkinson White, there are many others classified under that category. Okay.
Yes, sir.
Now, how do they perpetrate their act? What is the mechanism? First, I have to bring this image out to show you how the reentrant circuit happen. Okay. So in most of the time, when they are in their sinus reading, or you call the concealed type, when they have the concealed type, the patient will have normal SA node activity, right?
Yes, sir.
You generate normal AV node, and the east bundle, the right and left bundle, and Purkinje. And that one, you have a narrow complex, right?
Yes, sir.
Normal sinus reading. However, at that same time, the accessory pathway is inactive. At those times, that's why it's concealed. So the ECG you are seeing that looks normal to you is because the accessory pathway was inactive. It was not conducting.
Okay.
Okay.
Yes, sir.
However, by the time maybe an atrial premature complex happens or a ventricular premature complex happens, at those times, don't forget that the AV node will be in its refractive period at that time. Right?
Yes.
That is when this man will rear his ugly head. You get, and start conducting.
Yes. And conducting abnormal contractions.
Exactly. So it now depends on the direction at which it is conducting. That will explain the type of QRS you will see. Do you get me, man?
Okay, sir.
So I will take us to this image. I don't know if this is clear. This image, is it clear?
It's a little blurred, but I've seen it before. So
okay. It's also on the group.
Yes.
But I have to put this up so that we can see how the direction of conduction is. So can you see my arrow?
It's going up, the one you are talking.
Yes. Yes. So that is where the accessory pathway is. Linking the atrium and the ventricle together.
Yes, sir.
Around the area of the mitral valve. As I said, it can be on the right side, it can be on the, it can be anywhere. But for this image, this is where it is. Okay?
Yes, sir.
And for MCQ reason, Wolf Parkinson White accessory pathway usually on the left. just for MCQ sake. Okay, so let's move on. Let's move on. Now, this is where we are going. If you look at moment this accessory pathway become active, is the one that will be carrying impulse. What depending on the direction it's going, it can carry the impulse in a retrograde fashion back to the atrium. Are you getting me, man?
Yes, sir. Yes, sir.
And if it gets to the atrium, the only way it's going to access the ventricle is to use the normal conducting tissue, right?
Yes,
So
sir.
that means pass through the AV node, east, and the right and bundle, Purkinje, okay? And it's now going to go up back through the, the visual cycle we described for the other guy.
Yeah,
So it goes like the entrance circuit, goes up back through the accessory pathway, then comes down back through the normal conducting fiber. Now, here's one important information. Because the only way it is depolarizing the ventricle was through the normal Purkinje conducting fiber, then that means you should have a narrow complex QRS.
Okay.
And because the only way it depolarizes the ventricle, it came in the antigrade direction, using the normal conducting tissue. And we said anytime you use normal conducting tissue, you will have a normal narrow QRS complex. Even though there is tachycardia, that tachycardia will be narrow complex tachycardia. Are you getting it now?
Yes, sir. Yes, sir.
Now, remember that the first guy is the accessory pathway, right?
Okay. You didn't tell us that.
Yeah, it's faster. So this accessory pathway is faster than the conducting fibers, normal conducting fibers. But most of the time it is inactive until there's one APC or VPC that brings it up. So it has longer refractory period, but it's fast conducting. It's part of the MCQ in Brownwood.
Okay.
Are you getting me, man?
Yes, sir.
So because this accessory pathway, yes. So because this accessory pathway is fast, that means it's taking it back to the atrium very fast. And that will give you a short RP interval. So you can now see part of the slide where you saw that autodromic AVRT will give you a short RP. I'll go back to that slide. So you can see autodromic AVRT will give you. So I hope the two is now clear.
Yes, sir. So can I ask my question?
Yes, madam.
How can we differentiate the two?
Yeah, don't worry.
On ECG.
On ECG, no, it might be difficult to differentiate on ECG until you convert the person back to the sinus reading. Okay. If you convert the person back to the sinus reading, then you can now see features of AVRT. And what is the feature you are looking for? A short PR interval. Remember the features of Wolff Parkinson White or the pre-excitation syndrome. The PR interval will be short. But for AVNRT, when they are back in their sinus reading, it will be normal PR interval. Why? Because the fast pathway is not working.
That's at that level again.
Yes. Okay. So that is why they call autodromic AVRT conceal. It's concealing this nature.
Concealing the person he is.
He's a chameleon.
Trying to look like a VNRT.
Fantastic. You get, and even sometimes when they're in their sinus reading, you might not even short out interval because the accessory pathway might be inactivated. So it can be very, very terrible and concealed. But that is why you need to send the patient to EP lab to find out what is happening. And when we look at the EP images now, you will know how to differentiate them when you're in the EP lab. Okay?
Thank you so much. Yes, sir.
Yeah, I needed to explain all this because if you are going to the EP, it will be easy to decipher what is happening. And it will be easy to follow through rather than just jumping to the EP and be wondering what is this, what is they are just showing you. You understand what I mean?
I
Not be
do,
showing
sir.
you like, but I needed to explain this in total. Okay, so I'll
Yes,
come
sir.
back to this slide again. Dr. Copy, I hope we are on
Yes,
the
sir, we are
same
here.
page.
Okay. Ahead, ahead.
Those guys, they don't sleep. Oh.
Okay, sure.
They're always
Alright.
around.
Okay. Okay, man. So let's come to this second one. Remember we've discussed this,
Every day.
the one on your left hand side. Let's discuss on the one on your right hand side.
Yes, sir.
Remember the conducting tissue fibers can conduct in any direction. They can conduct from atrium to ventricle, right?
Yes, sir.
They can also conduct from ventricle back to atrium.
Yeah.
In any direction.
Yes, sir.
There's no limit to the direction of conduction for them. Anywhere electrical activity flows, it can
Yes.
flow there. Right? You
Yes,
know, the
sir.
same way you can send, if your wire is on the pole, you can, on your NEPA pole, you can bring wire through your wire, you can get electricity from your wire, Abby, to your house.
Yes, sir. Yes, sir.
But you also know that the same electricity can go from your house to the pole.
Yeah.
Yeah. So that means the wire, because it's taking it from the pole to your house, does not mean that it cannot go from the house to the pole.
Yeah. Yeah.
That's why sometimes it can spark on the pole.
Especially
So that's the same thing the electrical tissues can do. It can conduct from atrium to ventricle and from ventricle back to atrium. So that is what explains this second slide, this second image. So you can see that now the accessory pathway is the guy that is bringing it from the atrium to the ventricle. Are you getting me, ma?
Yes, sir. Yes, sir.
Why the east bundle and the right and left bundle, east bundle, AV node are the one taking it back to the atrium. So that is the word where you called antidromic. Right?
Yes,
it's
sir.
Clear, right?
Very clear, sir.
Now, don't forget that it is the accessory pathway that will depolarize the ventricle.
Yeah.
Simply because it's the guy that is bringing it from the atrium to the ventricle.
Yes, sir.
Why the guy that will depolarize the atrium will be the tissues of the AV node. Right?
Yes, sir.
So, because the accessory pathway is not a normal conducting fiber, and it will depolarize the ventricle from one side, start from one side before it spread to the other side. Unlike the AV node, if it was AV node that was bringing it, it will conduct to right and left bundle, Abby, and it will depolarize both sides at the same time.
At the same time.
But yeah, accessory pathway has to start from one side before it now spread to the other side, right?
Yeah.
So that means your QRS will be
widened.
Okay.
Yes, sir.
So that is why in antidromic, the QRS is broad. So that also explains why ventricular tachycardia too will be broad complex, because a ventricular tachycardia will start from one side, Abby, before it spread to the other side, from tissue to tissue spread. And before it takes time to depolarize everywhere, the QRS will take longer time. Okay?
Yes, sir.
So that is why a AVRT2 can manifest with a wide complex tachycardia that will look like VT. Are you getting me, man?
Yes, sir. Yes, sir.
Now, one final information I also want to buttress here is that they can also have long RP interval. Why? Because the accessory pathway is the faster one, right?
Yes.
And it's the one generating the ventricular activity.
Yes, sir.
Okay? The slower guy is the normal conducting fiber.
Yes, sir.
So it will take time for you to go and generate atrial activity.
Okay.
Accessory pathway is far faster. So QRS will have started before atrium is going to now start depolarizing because it's coming through from the slower fiber. So the RP interval may be long. Okay?
Yes, sir. Yes, sir.
And that is why in this our slide, we said long RP interval, okay, can be seen in AVRT, right?
Yes, sir.
Using this
Especially the
retrograde conducting.
anti.
Is it clear now?
Yes, sir. Very clear, sir.
It's very clear, right?
Yes, sir. Yes, sir.
Now, I want you to notice another word here. Atypical AVNRT can give you long RP, and the reason is not far-fetched, it's straightforward.
Atypical.
You know, this is AVNRT, right?
Yes, sir.
The typical AVNRT is that the slow fibers will take you to the ventricle, right? While the fast fiber will take you to the atrium, right?
Yes.
And by the time you are generating QRS complex, the fast fiber is also generating P wave at the same time, right?
Yes.
It's clear, B?
Yes, sir.
So that one, the
Yes,
RP interval will be very short, almost on each other. The R and the P will be very short. But what if, you know, it's not 100%. What if it's atypical? Atypical means that the fast fiber is the one taking it to the ventricle, while the slow fiber is the one taking it to the atrium.
Okay.
So it means that the fast fiber will quickly generate QRS, right?
Yes, sir.
Before the slow fiber will go and generate P wave. So that means that the RP interval will be long. Do you get that, man?
Yes. Yes.
So that is the atypical form of AVNRT. So for our level, we should know the typical, and we should also have an idea of the atypical. Do you get it, man?
I do, sir.
Chief Blessed, sir.
Fully with you, sir.
Okay, so we have understood the concept of AVNRT and AVRT. We've understood the concept of orthodromic and antidromic. We have understood the concept of short RP interval, right?
Yes, sir.
And long RP interval. Okay. So now let's go to the EP images now. Don't worry, it's not as long as you understood the concept, every other thing, it makes life easy for you. Okay. I think we've talked about this sinus cycle length before, SCL.
Yes, sir.
Yes, sir. Yes,
Just to quickly emphasize that using this image, that if I paste the ventricle, if I paste the atrium, you remember I said this catheter can sense activity, record activity. It can also be used to pace.
Yes, sir.
In fact, you can also, there's now a expression where you can use to ablate, to burn off. Now where I'm going is, this catheter, because it can pace, moment you pace the atrium here, that means that it will go to the AV node and pace the ventricle. Okay?
Okay.
If I pace the first time, it will conduct down. If I pace the second time, it will conduct down, right? The time interval between the first time I paced and the next time I paced is the sinus cycle length. Right? It's clear, right?
Yes, sir. Yes, sir.
But what if I stop pacing and I wait for his intrinsic SA node activity to take over? Are you getting me?
Yes, sir.
And so that means that the time interval between the last time I paced and the time the SA node took over is the what? Sinus recovery. Sinus node recovery time. Because we allowed the sinus to recover.
Yeah.
Right?
Yes, sir.
Yes, sir.
There is what is called AH interval. Atrium to east bundle interval. Before I go ahead, I always want to emphasize again that you can use your east bundle catheter as a reference catheter. Remember we explained the last time
Yes, sir.
that it is between the junction of the atrium and the ventricle.
Yes,
So
sir.
meaning that it can sense atrial activity with this proximal end. Abi?
Yeah. Yes, sir.
It can use this end to sense the east bundle activity,
Yes, and the other
which is
ventricle.
called H activity. And it can use its distal end to sense ventricular activity. Are you getting it, sir?
Yes, sir.
So that means you can have on your east bundle EGM, on your east bundle activity, you can have atrial activity seen on it, east bundle activity seen on it, and a ventricular activity seen on it.
Yes, sir.
Dr. Duduyemi, hope is clear.
Yes, sir.
Okay. It's very that important. Information is very important too. Now, AH means that the time interval from atrial to east AV node activity between the atrium and when it gets to the east bundle is AH. Are you getting me, man?
Yes, sir.
Between when it gets to from the east time to when it depolarizes the ventricle is called HV. That's the interval. It's not hard, Nabi.
It's not, sir.
Okay. So I had to use that to now come back to our intervals. I've already explained what cycle length means between each person. Sinus node recovery time between the last time you paced and when the SA node recovered. Okay. There's also what is called corrected sinus node recovery time. You just want corrected sinus node recovery time. You just want to ensure because the sinus node recovery time can vary a lot. So you can do like you do for QTC. You can do corrected sinus node recovery time. So it's just the difference between this and this. That means SA node recovery time minus sinus cycle length time is what will give you the corrected sinus node recovery time. The reason why you are doing this is to reduce variability. You know that you can pace at different rates when you start this thing. Sinus cycle length can affect the time when SA node recovery time will take of different rates at which you pace. You can be pacing at 300 millimeters per second. You can be pacing at 400. You can be pacing at 500. Depending on the time interval at which you pace, it can affect when the SA node will recover. Are you getting me, man? So to adjust for that difference in time is why you need to do corrected sinus node recovery time. Okay?
Yes, sir.
So when we talked about the AH time, this is the normal duration. We talked about the HV time, this is the normal duration. Are you getting me, man?
Yes, sir.
Now, there's a reason why I have to give us this duration. The reason is because when a patient has AVRT, atrioventricular tachycardia, AVRT, this HV time will be very short. Remember, it's a pre-excitation syndrome. So the AH and the HV time will be short. Why? Because their PR interval is short. Are you getting me?
Yes, sir. Get it.
Yeah, so we should focus on this timing also, that if it's shorter than the duration, that means there's a problem, there's a pre-excitation. Okay?
Yes, sir.
All right, so let's come into the image now. So don't be frustrated. This thing is very easy. Don't let anything harass you. So this is the normal EGM. Okay? You see the lead one AVF and V1 is the surface ECG, because you put ECG lead on the patient now, Abi, anytime you
Yes.
are in the EP lab. Now, it's easy to follow this alphabet, and I'll explain them. Remember we said there can be a catheter in the ventricle, right?
Yes.
Yeah.
So that's the catheter in the ventricle. Now, because I'll go back to this catheter. Now, I want you to imagine, if I put a catheter at the apex of the ventricle, do you know that the only thing it can record will be ventricular activity? It should not record atrial activity because it's far from the atrium. Are you getting me?
Yes, sir, we go.
I also explained that if I put a catheter in the coronary sinus, the coronary sinus lies in the atrioventricular groove posteriorly, right?
Yes, sir.
And the most posterior structure is the atrium and ventricle, left atrium and left ventricle. Okay, so that means it is the guy that is, and because it's lying in that groove, it will be sensing atrial activity and at the same time sensing ventricular activity. It will be the reference line for left atrium and ventricle. Are you getting me? Because it's lying in their groove. So the only thing you should be sensing should be left atrial and left ventricular activity, because it's lying in their groove. Just like east bundle catheter is sensing right atrium and right ventricular activity. Are you getting me?
Yes,
Dr. Koto.
I heard, sir. I'm getting you, sir.
Okay, Dr. Duduyemi, is it clear?
it's clear.
Hope Dr. Tony has not slept. Okay, all right, no problem. Okay, so we can see this catheter B, the right ventricular catheter B is in the right, Abi? Dr. Duduyemi,
No. We are still seeing the.
can you see my arrow?
No, your slide is not moving now.
I didn't hear it clearly, man.
I said your slide is not moving. We are still
My
at
slide is
that.
not moving.
Yes, we are still at. Okay.
It's moving.
Okay. Yeah.
Okay, so can you see
Your course, I can see.
can you see my cursor?
Yes, sir.
Now I'm putting it over the right ventricle, right? So it means the catheter that's the catheter for the right ventricle. That's how you label it, okay?
Yes, sir.
Can you see it is only sensing ventricular activity, depolarization? Are you seeing my arrow, my cursor?
Yes, sir.
And you can notice that ventricular activity is synonymous to QRS complex on the surface ECG.
Yeah.
Abi?
Yes, sir.
And it's only sensing the next ventricular activity, which is the same representing the surface. So always know that when you're interpreting EGM, you should interpret it in relationship with the surface ECG. Remember when we are looking at that programmer 1-2, when it was saying VP, V sense, V pace, V sense. Remember it was in relationship to the surface ECG.
Yes, sir. Yes, sir.
So we are trying to emphasize that anytime you are doing EP activity, always equilibrate your images to the surface ECG. Abi? So you can see. So you can see that this QRS, this ventricular spike or activity is related to the surface QRS complex. So that one is sorted down, Abi. So HR A. Remember we said some catheter can be in the right atrium, high right atrium, as close to the SA node as possible. Abi? So that's what you are seeing here. Remember, it will not sense ventricular activity because it's close to the SA node. So how can it be sensing ventricular activity? Abi?
Yes, sir.
Remember that image we put up.
Mm-hmm.
So that means the only thing it's going to be seeing should be the P wave.
Yes.
Hmm? Sorry that the
Yes.
P wave is almost flat out here, but that is the P wave. My arrow is over it. Hmm?
Yes.
Are you getting me, man?
Yes, sir. Yes, sir.
So it's sensing atrial activity. Hope you are not feeling sleepy, Dr. Dudu.
A little, I'm feeling a little sleepy. Let me position myself. But I'm
Dr. Kopi,
following.
what do we do now?
No, I will.
Even Dr. Tony has slept.
Dr. Tony, a busy day.
I am fully awake and I'm following.
You are fully awake. Okay, glory be to God.
People are fully awake. Oh.
Dr. Dudu, I want to send Jumia to bring you coffee. Oh. Say you open door for
I
them.
actually have one with me. Let me try again.
Okay. Please, I need you to be here.
I need to be here myself. I know.
Hello, sir. Should she sleep later? We'll give her the recording and explain.
No, don't worry. I'm awake. Let's continue. I will show you today. I'm around.
Okay. So, but you can see this atrial activity, right?
Yes, sir.
Yeah, as I said,
Yes,
corresponding with the P wave.
Yes, sir.
Atrial activity. It only says atrial activity because it's in the eye right atrium, right?
Mm-hmm.
Yes, sir.
So that brings us to the HBE, is the East bundle. Okay?
Okay. Yes,
catheter, East bundle catheter.
Okay.
So remember that East bundle catheter can be proximal, there's a proximal hand and distal hand to it. Remember, I explained.
Yes, sir.
It's the same catheter, but there are some polar hands that is proximal, there are some polar hand that is distal. Remember I said that the one proximal can sense the atrium, Abi?
Yes.
The one in the middle will sense the east, and the one distal will sense, Abi, the ventricle. Should I go back to the slide?
No, sir.
No, sir.
Okay, great. So you can now see the one they labeled A, atrium, and it corresponds to the eye right atrium.
Yeah.
Yes, there's a little time distance between the eye right atrium and the A. Why? Because the eye right atrium is close to the SA node, Abi?
Yes.
And the pulsation should continue down, Abi?
Yes.
The AV node is more at the junction. So that's why you have that little time distance. Are you seeing?
Yeah.
Are you getting it now?
They're not really aligning like that.
Yes,
100%.
but you know that they are related, Abi?
Mm-hmm.
You see the next guy, they called H.
Yes.
Is the East. Remember, we said the East is the middle guy before you get to the ventricle, Abi?
Ventricle. Yes, sir.
So you can see V, the ventricle, Abi?
Mm-hmm.
So remember those interval we talked about, AH, HV.
From the atrium to the east, then
right?
Yeah, from east to ventricle, yes, sir.
Yeah, and you can see to further buttress that this place is V. If you look at the QRS complex, is at the same time with the QRS complex. Abi?
Yes, sir.
You get that now?
Yes, sir.
So what we are trying to emphasize here is that the East bundle can serve as a reference line.
Yeah.
You can see that it can serve as a reference line for you to look at your atrial activity, East bundle activity, and ventricular activity.
And ventricular. Yes, sir. Yes, sir.
Right?
Okay.
So that one has nailed that point, Abi?
Yes, sir. Yes, sir.
So Dr. Dudu, just be ready for your certificate of EP after this time.
Yes, I'll be glad to receive it and glaze it.
Okay. So CS, we all know is the catheter in the coronary sinus, Abi?
Yes, sir.
So we all know that we explained that the coronary sinus is for the left atrium, Abi?
Yes, sir.
And the left ventricular activity, Abi?
Yes, sir. Yes, sir.
So and remember that the right atrium will first depolarize before the left atrium. Abi? So you can see that short distance, Abi, between them.
Yes.
Right?
Okay. Yes.
And we said that sometimes the CS catheter can also sense something in the ventricle, Abi. So you can see all this, Abi, which corresponds to your QRS above, Abi.
Yes, ventricular, yes, sir.
And it's representing left ventricular activity, Abi.
Yes, sir.
Yeah.
So we're just trying to emphasize that your CS catheter too can be like a reference line for the left side. Right? So I think this slide is clear.
Very clear, sir.
Yeah, but
Do you have any question on this slide before we start? Yes.
I don't.
Why is it labeled? Why is it labeled 1 to 2, 3 to 4, 3 to 5, 7
Fantastic.
to 8,
Thank you.
9 to 10?
Slide for that question. Remember we talked about this, right? Hello, Dr. Tony.
Yeah.
Dr. Tony.
I can hear you.
Slide. You can see my slide, Abby. The catheter.
Yes, sir. Yes, sir.
Remember I told you there are white parts, Abby, on that slide, on that catheter.
On the catheter.
So, hand, are you getting me, sir?
Yes.
So depending on the number of polar hand, you are the one that will determine which one you want. You can use only one that have 2 white markers. Okay?
Yes,
Get to be bipolar. You can introduce 4. You can introduce the one that has 8.
Yes, you said that.
Well, are you getting me, doctor? Decapolar.
It appears that the network was giving some issues.
So they just numbered it based on the number.
The polar end.
Are you getting me, sir?
Yes, sir.
Hello, sir. Sorry, sir. The his bundle recording on the tracing. Yes, I see D. Does D mean distal and the P proximal or F?
Yes, let me show you again this place. So let me show you again on this place. Can you see this my catheter hand?
Yes, sir.
Can you see my catheter hand?
Yes.
So I can decide on my machine. I'm the one that will put it that this segment will be proximal, this segment will be mid, and this segment will be distal.
Okay.
Are you getting me, sir? Yes, also for atrium too, I can have high right atrium or low right atrium, depending on the place I put my catheter. My atrial catheter here and call it low right atrium, or around here and call it low right atrium. Or I can call it distal, as in proximal, mid, and distal. You are the one that will fit. You are the one that will put your abbreviation, your labeling. You get, doctor? The same way for the RV apex. I can have RVA, I can have RV mid, I can have RV proximal, depending on how I put my catheter.
Okay.
Okay.
All right. Yes, sir.
So that's how it goes for the labeling. Don't worry, I've seen those people change the codes, and I can decide that I only want 2 readings for coronary sinus and close. Because if you have seen the machine, it's just like a laptop. You can close this end and decide only what you want is just 2 settings for coronary sinus.
Okay.
What I'm saying so is that by the time we start moving to the question hand, you might see some that might not even have RV. They only be right atrium, or you see different right atriums.
Yes, sir. Yes.
So it's depending on how the catheters are placed. So I think that one is straightforward, right?
Yes, sir, it is.
So, doctor, please, does anybody have question on this EGM before we go to the question side?
Wow.
Look at this EGM very well. EGM is a word. What's this? EGM, electrocardiogram. EGM word is used. Electrogram. EGM word is used when your catheter is when your catheter or your pacemaker lead is recording directly from the myocardium.
Okay.
ECG is the word you use when you are using surface ECG to record electrical activity of the heart. EGM is the word you use when you are using catheters directly on the myocardium.
Okay.
So that when you see me using the interchanging words EGM, ECG, ECG means it's surface to determine electrical activity. EGM means it's intracardiac. Okay, so please, do you have any question on this EGM?
No, sir.
So can we move on now? Okay.
Yes, sir.
So, Doctor, do you hear me? I brought up this slide again. Yeah. So I brought up this slide again. As Dr. Kopi asked, remember Dr. Kopi was saying that why did he label it middle? He was asking me. So you can see this one, Dr. Kopi.
Yes, I can see.
You can see the surface ECG. I chose the patient, they just chose V1 and V5 only.
Yes, sir.
They only chose to put two catheters.
Yeah, mid and distal.
The bundle, now the East bundle catheter and the RV catheter. Those are only two catheters that they put.
Okay, yeah, I can see. Yes.
Okay. I had to put this up so that you can understand something here. But there's a pathology here, which I need Dr. Duduyemi to look at. Yes, now you know we'll call you now, madam.
Okay, so let's see. Well, looking from the ECG, something that is glaring, there seems to be a pause somewhere.
Fantastic. That's the first word. There's a pause somewhere. Yeah.
Yes.
There's a pause somewhere.
So, I'm not too sure what that is, but at least that seems to be so widened. Let me see what I will call it. I'm not too sure. Okay, let's see. This East bundle may be able to help me.
Fantastic.
Okay. East bundle.
That PRO interval, there's something about it.
Okay. But you looking at the East bundle, the distal, the mid, they are able to explain it better. At least that port is not that large there. So if one can interpret it, one may be able to say where the problem is. Well, let's start. Let me try and maybe look at it from the East bundle. Let me use mid. Now I can see the first wave correlating with the P wave using my surface ECG. Then I can see my QRS complex. I'm not sure what this is, but could it be, I don't know. I mean the funny movement, the negative and the positive one in between. There's nothing really correlating to that on my surface ECG unless I want to take it as my T wave. Can you see what I'm trying to?
I get what you're saying.
To explain. Okay, so I'm not too sure what that is, but I can move in again. So that one, I'm not sure what it is. It will have been able to help me. But I'm not sure, maybe it looks like, okay, so looking at that one, then I can see another P, the ventricular, then it's coming again. But now, then the pulse, I can see the pulse area, nothing is there. Then this another contraction, unlike the previous one that I'm not sure, maybe they are T wave. It's having a positive deflection, then a negative one. It is not a P wave. I'm not sure what that is. Can you see what I'm trying to show?
Yeah, I get what you're saying.
Yes.
Okay, so fantastic. I'm happy you gave a great attempt to this, and I'm also very much happy that you actually identified the pulse, the delay around here. Okay.
Yes, sir. Yes, sir.
So there was, as you said, a natural activity around here.
Yes, sir.
Then if you look at your ventricle, there was also a ventricular activity. Okay.
Yes, sir. Yes, sir.
Down here. Okay.
Yes, sir.
All right. Yes, I'm sure you said you are not sure what this is, because
Yes, sir.
sometimes when it's not well filtered, you have some EGM you'll not be able to explain. Okay.
Yes, sir.
But the real problem here is there was a delay, there was a drop here, meaning that you did not see any ventricular activity around here.
Yes, sir.
Right? So that means
Yes,
there's a
sir.
drop of a QRS.
We can't see your arrow.
I can see.
You can't see my arrow.
Is that the lower down?
Okay.
Yeah.
You can see it.
I was trying to focus on the RV. You can see the right ventricular activity, right? Ventricular activity.
Yes, sir. Yes, sir.
Dr. Tony, you can see it, Abi?
I can see it now.
But there's no ventricular activity around here, right? But there's a ventricular activity and a ventricular activity here, right? So that means there was a drop of QRS in between here, right?
Yes, sir.
Okay. Another thing you want to check for is that is there a progressive prolongation of PR interval? Okay.
Yes, sir.
Because so I want to bring up my arrow. If you notice, their activity in the distal is here. But I expect a corresponding ventricular activity around here.
What do you call that? That one, that activity. What is it? Is it a T? Is it a T?
So technically, if you want to actually really analyze this thing very well, you should have some atrial activity around here, and the next QRS should fall around here. The next QRS should fall around here. So that means there's a drop of QRS activity here.
Okay.
Why?
So I have a question.
We'll go to images that are clearer. But what I'm trying to emphasize here that you identified here is that there's a drop of QRS activity here.
Okay.
You get, meaning that
yes, sir.
The AV node did not conduct in this place. So there will be loss of HV in this place. Remember, HV is the conduction from the east down to the ventricle. There was no HV activity here. Okay.
Yes, sir.
What we will need to now check is if there was consistent prolongation of AH.
Yes.
Until they get to a stage where you cannot see HV. Or the V is missing. If there's no consistent prolongation, then it's a Mobitz type 2. Okay?
Yes, sir.
There are still more slides that will explain further to us, then we'll come back to this slide. But let me get your question.
My question is this. But of course, you said maybe where we see a clearer picture.
Yeah.
Now, going by the surface ECG and this the EMG, am I right? We are able EGM. We are able to say that the first upward deflection is the atrium.
Yeah.
right?
What will have helped us? Yeah. What will have helped us was if there was an. I understand where you're going. If there was an
Okay.
HRA
Okay.
catheter,
Okay.
it will have been very more easy to follow.
Yes.
You will have been able to say distinctly say that okay, oh, I can see
This is already
HRA showing atrial activity. I
mm-hmm,
can see RV catheter showing ventricular activity. What's the distance between both of them?
Okay.
When is the RV missing? But we can know that there's a missing RV activity here.
Okay.
You understand? So that's why I'm also not sticking my neck out. You see what? That's why I'm also not sticking my neck out to say this is working back or not working back. But there's a drop off. If there's a AV node problem here.
Okay. Okay.
Okay. So we have to start with the difficult one. Another difficult one, right? Now they provided us with the HR activity.
Yes.
So let's use opportunity with the HR activity now.
Okay. Can I go ahead?
Yes, madam.
Okay, this will be a little effort, at least considering that we have the right atrium here.
Fantastic.
So we can appreciate our P wave, the atrial contraction.
Yes.
And we have our RV apex, which is even not showing at all the atrial. But of course, we can now appreciate the distance between the two. We can say, okay, this is our atrium, this is our ventricle.
Fantastic.
Well, now let's look at the is distal. We can see that the is proximal, we can appreciate our P wave and our QRS complex. But looking at is distal, proximal distal, is it the distal one? Is it the one closest to the right ventricular apex?
Yes.
Okay, so is that the reason why we are not really seeing? Okay, but now where you are touching now, that is that's the atrium.
Fantastic.
But I can't see it in the next one. I'm not.
Yes,
maybe
so
that's
it's not telling exactly.
Maybe that's the problem.
And again, look at here.
And it's also not up. Then you now see it. Then you are not seeing it again. Okay, so that's another atrial contraction, but it's also not at the second to the last complex or beat.
Fantastic. Then it's not here again, right?
Yes, sir.
Now, one last thing to compare is compare the distance between this atrial activity and this ventricular activity. The distance.
Okay.
Here it is absent, right?
Yes, and this
compare
one
the
is also
between
very far away. So we can say it's progressively increasing. There's a drop, then it's up. But what the diagnosis is down? Or we need a longer strip to be able to assess.
So what I'm just trying to emphasize here, I think what we are trying to emphasize here is that there's no relationship between this and this.
Okay.
Because it's not, you can't even see it here, no relationship. And look at the distance between here and here, no relationship.
So is it important for us to check if sorry, I want to ask a question. To check, in complete heart block, the PP distance are constant. Can we check if these are constant? If it is regular, I mean to say.
So look at it now. So look at this. Look at the distance interval between here and here, and the distance. Sorry. So look at the distance interval between here and here.
Yeah. Okay, they seem to be regular.
And the distance interval between here and here. Exactly.
Yeah, they seem
Look
to
at
be
the
regular.
ventricular activity too.
They are
Look
also
at the distal
regular.
interval between yeah.
Okay.
Yeah.
Complete heart block.
So it has made your diagnosis.
Okay.
Right?
Yes, sir. Thank you, sir.
Dr. Kobe.
Hello, Chief. Before you continue. Hello,
Okay.
Chief. Are you
Dr.
there?
Kobe has left.
No,
I'm
I'm
here.
here. I'm fully
Chief,
here. I'm
why
fully.
will you want to do an EP study for complete heart block? You can get that from surface ECG.
You know, I thought of it even initially that even why do we have to do it? Maybe because we want to do ablation. I don't know. Maybe you will tell us.
Okay.
Because I was like, all this we can always speak on the surface ECG.
Let me see if I have one video to show you. It's a fantastic question, Professor Tony has asked. But there's one easy way to just answer his question. You know, when professor asks question, and you can't just answer any other. Abi?
Yes, sir. Yes, sir. I agree with you, sir.
I want to see if I can get the. I want to see if I can get one video to show professor. Just 1 minute. Let me just see if I can get that video. I remember I loaded that video. Susan. Susan. Jesus. I wanted to show him. I saved that video somewhere. I thought, Doctor. Oh God. Okay, you know what we'll do? When I get the video, I'll answer Dr. Tony. This is not because it is late. I thought I saved that video somewhere. I will have answered Dr. Tony now. Okay. No, Konai pacemaker program. No, Kojadi now. Okay. I'm not seeing that video now. Thought I brought it out one time. No, I think I brought it out. Okay. Dr. Tony. Hello, Dr. Tony.
Yes, I'm here, sir.
You see, there was one time we had a patient that had complete heart block. Okay. We're about taking her to the theater for permanent pacemaker. So by the time we took her, we just said, let's just put her on the cardiac monitor. Are you getting me? We just said that let's put her on cardiac monitor before we take her into for the procedure. Do you know surprisingly what we saw? Guess what we saw on the monitor?
Artifact.
Eh?
Artifact.
No. So what we saw on the monitor was non-sustained VT.
Wow.
So simply meaning that if we had put pacemaker on that patient will have died on the table. Because patient was just entering VT on table. Patient actually had complete heart block. I will send you the ECG on my. I thought I'd pull up the video of the NSVT. Yeah. So look at, I've sent the ECG to the group. I'm sure Dr. Tony would think maybe they don't even know how to make a diagnosis of complete heart block. Dr. Tony, look at that ECG. Hello, Dr. Tony.
I'm here.
Yeah. I want you to have a look at that ECG. And tell me what you think about that ECG. Doctor, do you hear me? Can you see the ECG?
Yes, I'm actually looking at it. Yeah.
Good.
You can see P-wave actually doing their thing, and they are not related to the KRS complex there, because I can see P-wave on top of QRS complex just after the S, just before the T on ST segment. One can see P-wave there. Then I'm sure there's actually one that is embedded on the R too. And I can see okay, then I can see one just after the uprising, the upstroke of the T wave too. Like that. So I can see all the P waves doing their thing like that. Then I'm also sure the rate is also slow, low.
Yeah. So
Just
what would you have thought? Oh, what would you have thought of the diagnosis?
I think I will still think of a complete heart block there.
You'll have thought of complete heart block, right?
Yes.
Yeah. Dr. Tony, anything against it?
yeah, well, nothing against it, but looking at the T wave, the deep inverted T wave, it will have also give me a pointer to something more. Could it be that this patient is having left main disease? Could it be that
I
this
didn't get
patient?
it clearly. Your voice is not.
Could it be that this patient is having left main disease? Could it be that the patient is having some form of ischemic process going on because of this deep inverted T
But
wave?
okay.
So I want to think.
So I'll tell you one thing.
Wait, before you tell us. I'm just trying to look at the QRS complex again. Okay, I can see lead 1, 2, 3. That's AVR, Rabi. Sir, is that AVR after below the third, below the 3?
Yeah.
It seems to be upright. Am I right?
I didn't get it clearly. AVR below the 3. Or let me show. I sent multiple.
Yes, I'm checking the first
yeah. It's AVR below the 3.
It seems to be upright.
Okay.
I can't see very well. I know that the lead 3 is entering it, but I'm not too sure. And the AVL is upright. AVF is also inferior. The reading strip is the last one, which is lead 1, right? No, it can't be lead 1. Lead 1 is upright now. Why is it negative again here? The lead 1, the first one is lead 1. Why
I
is it
think it's
negative?
lead 2 you are saying, lead 2.
Okay. Okay. Okay, I give up.
Give up. Why?
I don't
No,
know.
are you saying you are changing your mind from
I'm not changing my mind. I'm not changing my mind. I'm not changing my mind. It's still complete at block. Um, the inferior leads, uh, they are negative. Maybe it's just telling me about the axis, like LAD. Um, then inferior leads, the Q wave, they are like inferolateral ischemia too. Yes, because it's also seen in the V3 to V6. The T wave are also um, inverted, and also the inferior leads. But this AVR, it seems to be upright. Why will it be upright? I can't see the T wave there is upright. I can see that very well. But the QRS complex, I'm not too sure where it's looking at, which I mean makes it but uh the P wave is negative there too. So I'm not too sure why the T wave should be upright on AVR. So that's the little I can see, sir.
Well, to also add to it, going back to the British strip,
Okay.
starting from the beginning, see a P wave, you see a P wave again, then you see a QRS complex, then you see it appears there's a P wave around that after the QRS complex, but after the inverted T wave, you see another P wave, another P wave, another P wave, QRS complex. And again, after the inverted T wave, P wave, P wave, P wave, QRS complex. P wave, P wave, P wave, QRS complex. So this appeared like have three impulses, four non-multifocal impulses, like 4 atrial activities gets to the AV node, only one is conducted. So it's appeared to be consistent almost across everything. So you're seeing like, although the first, so it appeared like 4-to-1 block, AV nodal block. 4 activities conducted. No, sorry, 4 to 3 blocks. Sorry, 4 activities initiated by the atrium or the SA node, as case may be, and 3 are blocked off. There's only one that is conducted. So these appear like 4-to-3 AV nodal block.
Why do you say 4-to-3? Why not 3-to-1? 1-to-3 or 4-to-1?
Because 4 activities are conducted.
Are not conducted.
So 4 activities are initiated by the SA node
or
as case
and
may be.
only
one is conducted. So 3 is blocked. The block of 3, 1 is conducted. So that's 4-to-3 AV nodal block.
I don't think. Okay.
Tony, since we need to close, the sleep is now touching. Your easy interpretation is getting affected by the sleep. We need to. It's 1:30 a.m. Probably we would have to reschedule.
Okay.
But interestingly, everybody is still awake on the group, on the Zoom meeting. We still have how many people? 9 people now.
Don't be deceived, though.
We're 14 before, but we're not 9 persons.
Yeah, nice.
Yeah, so a lot of people have just
And it's only 4 people that are talking.
exactly.
Okay, we've increased.
I'm talking too.
Okay, Dr. Blessed. Yes, I can see.
See, that thing is not third degree block. Looking at it again, it looks like there's no complete AB dissociation. There's no AB dissociation. There's a relationship between the atrium and the ventricle.
Yeah.
It's more of 2:1 AV block.
It's not 2:1 now. You are
3:1.
Oh Jesus. I beg, let's go and sleep. I beg. I don't even know.
It's not 2 now.
Let's
After
crack out this thing before we sleep.
the inverted T wave, there is a P wave. There is another P.
Yes.
Wait a
P.
minute.
Yes.
Before you see the block.
Okay.
So maybe I'm looking at it again now. 3:1 block.
3:1.
Sorry, it wasn't 3:1 because you have 3 atrial activity.
1 ventricle.
One ventricle.
Initially, it was taking like third degree, but when you look at it again,
I was thinking, is it 3:1 or
unless it's a high grade block.
Is it, of course, is
a complete. Another question I actually have is that how can one, but really, okay, because sorry for the way I'm talking, but really in high grade block, we can actually have something like this that looks like a complete heart block. You can really have it because really looking at this, I would have appreciated if I can see a tape or a paper to actually be able to pick out those P waves. Those P waves. I think there are a lot of them that are entering into the QRS complex. And if that is the case, okay.
No, ma. I think. Are we looking at the same issue? I think this is a clear morbid type 2, 3:1. You can see the prolonged PRO interval and then prolonged PRO. That I'm looking at the first ECG posted though.
Yes,
that's
that's where
ECG?
I am. Yes, that's where I am. That's what I'm
PRO
saying.
interval is prolonged. PRO interval is prolonged, and then we see that there's a relationship. It's 3:1, 3 P waves to 1 PRS complex. That's what I can see.
Sorry, let's look at the first QRS complex. How are we so the very first QRS complex? Just you can see the R. Okay, let's check the redeem strip. Or let's actually go to the lead 2 on the up side so that we won't have interference from the AVF entering into it. Now, the QRS complex, okay, there's a first the P wave, then the upward deflection, the downward, then the upstroke. There seems to be a P wave between on the ST segment. I stand to be corrected. There seems to be another P wave there. I stand to be correct. I may be wrong.
If you look down to the other recordings, look down to that AVR, you won't see anything like that.
Does it follow to the other one?
If you look at the other readings, if you look at lead 1, I think I also noted that upward deflection.
If we look at lead 1, is there.
Yes, there's a little
just there. Where it's difficult to see is actually on AV, maybe hell. I'm not saying it very well. It's difficult to really appreciate on AV.
It's even there very tiny.
But is there on AVF?
I can say you're talking about.
But I think what is clear is that the P wave before the QRS complex is prolonged. The PR interval is prolonged and is related to the ventricular activity. That's what is clear there. And if you look at lead 2, the reading strip, you understand after the inverted T wave, there is a P wave, there's another
Let
P
me
wave,
let me
another P
let me
wave.
let me let,
All
let
these
me
QRS
let me
complex.
let me give us a little more confusion. Sorry. Now let's look at the last the reading strip. The first
Yeah,
QRS complex, the second QRS complex, the third QRS complex. Let's look at the fourth QRS complex. Look at the P wave preceding that. What will you say to that P wave? It is not prolonged, right?
appear normal.
It appears normal. So I think the relationship, and let's go back. That P wave, the preceding one to it, the next one to it, those distance between the two of them seems to be equal. But I don't think those P waves are related to the QRS complex. Of course,
You're
there
right.
will,
You're
there,
right. You're
there, there
right.
will definitely be one that precedes that QRS complex. That will be a
You're
P
right.
wave.
You're right.
Let's
You're right.
settle now this so that it will just
You can
let's
go and
just
look.
it's high grade, second degree.
No, I think it's third degree.
There
I
is
No,
think.
even
I
it's
the
think
high,
third degree.
I
it's
If
think
it
high
is
the
high
grade.
point,
grade, you see, it's
the
still
point here is that I think what Dr. Oladimeji is trying to pass across to me is sometimes it's difficult to make the diagnosis.
No,
Whether
this
this,
diagnosis. Yeah.
we have to go
he's
and do
saying
EP.
that he's trying to tell us that we may, our question is, if all these diagnoses can be seen on the surface ECG, then why this EP? Why are we
yeah,
doing this thing? So he's trying to say sometimes the surface ECG can be confusing, and it is when we do that
EP study that you
myocardial
can.
that you now pick it. So we want to allow our our emeritus professor Oladimeji to sort us out tonight so that we can go and sleep.
No, so before we go and sleep, before we
Yes,
go and
sir.
sleep, I really want to, when, as I said, when Professor Tony asked question, Dr. Kobe, don't be angry. Well, if you know where me I met Professor Tony met, you know why we are doing like this. So when Professor Tony asks question, you have to prove beyond every reasonable doubt that you get what I mean. So Professor
Yeah,
Tony, I'm going to play a video now,
It's a wasita.
and Dr. Kobe,
Yes, sir.
when I play the video, then you can sleep with the video.
Yes, sir.
You understand?
Yes, sir.
So I just want you to watch this video, so you can now be the judge. I want you to be the judge of the question that
Okay, sir.
Professor Tony asked. So I'm going to share
Yes.
my slide now. This belongs to the same patient. Okay. If you can see my slide, let me know. Can you see my slide?
yes,
Has it appeared?
yes, it has.
Yes. Yes, sir.
Okay. Now good. I'm going to do one thing. I'm going to play the video. I want to follow with you the video. Okay. So tell me if the video is playing. Is it playing?
Yes.
Okay, so
It's
this belongs to the same patient. Just keep watching the video. You see what I mean? Keep watching the video. You can see the severe bradycardia, right? Because sometimes you look at ECG and just think, oh, this is 2 to 1. Can you watch this video very well and look at the relation of the P wave and the KRS? You can see they are dropping at their own times. So you use. So did you see that?
Yes,
Okay.
What did you
That's a
see?
VT right there. That's a VT right there.
So Professor Tony,
I'm
watch it
here.
very well.
Hmm.
I want you to watch it very well. So can you see? Will you have taken this patient to go and do pacemaker for this patient?
Not at all.
Eh?
Not at all.
Dr. Kopi?
No, not at all.
You know, that's why I said sometimes textbook might not be straightforward like that, but life cases would turn your understanding very well. Because the patient had bought the dual chamber pacemaker, we're about going to the theater. And my colleague just said, let's put this patient on monitor now, at least before we are going to the theater. And lo and behold, we just kept on monitor and we saw that kind of a thing. So we look ahead with double chamber pacemaker. So you can see that even those people say, somebody has complete heart block, why should you go and do EP study for the patient? This is a kind. Are you getting me, sir?
Yeah.
Yes, sir.
No, I had to stop. I had to allow you guys argue so I can find out the video to show you, because we kept this as evidence. So that before they are harassing us tomorrow, that why will you put somebody with double pace and somebody with complete heart block, why you put him on ICD before they start accusing you? This is an evidence, Abi. So we now found out that patient was actually has background inflammatory cardiomyopathy, not just infiltrative, inflammatory cardiomyopathy. Patient was treated for connective tissue disease, has been on azathioprine, has been on steroids. So you'll have thought, oh yes, connective tissue disease will have caused degeneration of the conducting fibers, right? And they will present with complete heart block. But don't forget that they can also present with abnormal, and they can have substrate for VT that can start discharging anyhow. If that patient had been on pacemaker in the theater, you just found that the patient did not wake up the following day. Do you know that even after the procedure, patient had sustained VT while in the theater? When we even put in the ICD, we had to shock. Are you getting me, sir? By the time the patient, after the whole procedure, patient was admitted overnight, patient had 2 shocks from the ICD.
Wow.
Or else they would have said, we spent a lot of money to do pacemaker, now I can't, patient can't die. They say it was the procedure that killed the patient. I don't mind them. They are just playing with the procedure inside the theater. They don't, those small boys, I don't know anything. So with this viewpoint of mine, Dr. Kopi, I'm sure you can now sleep well.
Yes, sir.
We can now continue another time.
Thank you
So
so
Dr.
much.
Tony, hope that answered your questions.
Sorry. So what is the answer to that ECG?
No, I played the. I know you have sat down with ECG. You have thought maybe it's 3-to-1, 4-to-1 block. But when you were looking at the video I played, didn't you see? Maybe I'll post the video on the group so I can follow the video reading. It's because it will also show you how the P wave was almost dropping on the QRS complex. Then you cannot make up your mind if it's actually 3-to-1 or it's complete block.
Okay.
I will send the video to the group. So please, Dr. Tony, help me archive this video for future purpose, future reference.
Okay.
Sure, get. Archive the ECG, archive the video. You can use it even when you are teaching anywhere. Anybody can use it anywhere. That if somebody's asking you, why should you be doing alter on somebody that has complete heart block? Why should you be doing EP on somebody that has complete heart block? These are evidence, video evidence, to show that you've seen a case like this before. You get, sir?
I wasn't going to just say just now that all those my patients with complete heart block, shouldn't I go and do altar for them?
No, don't do it for all of them. It's not for all of them, but I'm not saying that there are to be some rare cases that will just have an indication for it. You get?
It's shocking.
So, Chief, guys, just let me keep it because I had to look for this video for a long time. So I want you guys to also archive it somewhere. ECG and the echo. Just let me archive it on your. Is for sharing, for future sharing. Thank you. I'll post it on the group. All right. Have a blessed time.
Thank
you so much, sir.
Thank you, sir.
Please, just before we go, I'm sure a lot of people already not here again. We're up to 14 at the time. There were 9 now. That means 7 persons have left us. So it's been an interesting night. Just so some few information for those of us that are interested in coming to Tri-State. Uh, I know that earlier on it was posted that there was a little adjustment to the program into batches, batch 1 and batch 2. So I had to find out why there was a change. The information was that I think Tri-State as the center have some surgeries that they need to also cover. And the focal person in charge of the surgery will be making a trip somewhere around on the 14th. So we need to finish all the surgeries within that time interval before we start the second batch. So well, I was of the thought that for those of us that will show up on the 30th, you have 30th, 31st, 1st, and 2nd. That's the first batch. You know, had earlier on said that it will run between 30th and 8th of June. So, especially for those of that book flights, return flight tickets by the next day, that's on the night. It's not also wasted because there'll be a lot of cardiac surgery. So, if you had not experienced open heart surgery, this is also a time to take advantage of the procedures. I'm sure CAPG, atrial valve replacement, aortic valve replacement, and all the likes, a lot of VST repair, not many other things. Then we can also take advantage to look around some of the cases they have interested. They tend to have some very interesting cases that you will naturally not see some around because it's the center where they do a lot of referral. So you see a lot of beautiful cases, and I'm sure they can also oblige us to go through some of the archives. So I said that to say that even if you have made arrangements, you don't have to be discouraged because after the first batch, you can also have access to, or you can watch some surgeries, especially open heart surgery. And like Dr. Oladimeji have told us before, there are a lot of patients. And for people that will be interested in hands-on, I'm sure we'll have the privileges and the opportunity to do that. So once again, thank you. Let's know that whatever is happening there, it's being organized by the Cardiovascular Educational Foundation, of which Dr. Emeroli is the chairman, and it is well recognized by the Nigeria Cardiac Society. So whatever we're doing right now, it is not just for the fun of it, it is endorsed by Nigeria Cardiac Society. For some of us that have not signed our workbook on, if you look at the workbook, there's a column for interventions and there's a column for surgeries. It's also a time that you can come along with your logbook so that you can sign that aspect. Because sometimes you may not be able to sign some of these things in our regular hospital. So once again, thank you. Thank Dr. Oladimeji. Thank everybody that have been on today. May God continue to bless us.
Dr. Tony, please give us update on accommodation so that we know where we are coming.
Okay, like I said, I'm going to make a call later today, but the information I had before, Shagamu is the, sorry, let me just pause my record. I didn't know that was recording. This recording